Very good morning, everyone. So, ladies and gentlemen, today I'm Dr. Prasanna Kumati, Associate Professor from the Department of Respiratory Medicine. On behalf of the Department of Respiratory Medicine, I welcome you all for today's program, CTD, which is Connective Tissue Diseases Associated Interstitial Lung Disease. So, I take immense pleasure to invite our Principal and Dean, Dr. Shalini ma'am, to the dais. I invite Dr. Hemant sir, the registrar, to that. I invite Dr. Senior Professor, Dr. Gayatri Devi Chief, to come on the dais. So, the scope of today's talk is CTD ILD. So we know connective tissue diseases, the group of heterogeneous disorders. So it is characterized by autoantibodies. So to name some diseases like systemic sclerosis, rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, and so on. So similarly, the interstitial lung disease are also a heterogeneous group of lung disorders characterized by lung injury as a consequence of systemic autoimmunity. So today we have a multidisciplinary panel of expert speakers here who will keep you engaged and the sessions to come for next 3 hours with case discussions and so on. To kickstart this morning's program, it is my immense pleasure to invite our Senior Professor at Head of the Department of Respiratory Medicine, Dr. Gayatri Devi, to deliver the welcome address. Madam is an authority on the subject of CTD ILD and has been distinguished speaker on this topic at numerous state and national level conferences. So, ma'am, please.
Morning, respected Madam Dr. Shalini, our dear Madam Principal and Dean, Dr. Hemant, Registrar M.S.Ramaiah Medical College, and Joint Registrar and Director of Admissions at Ramaiah University of Applied Sciences, the faculty and students of Ramaiah Medical College. And outside the faculty, we have outside faculty as well. I welcome Dr. Tanil Gupta and Dr. Harshini to this CME program on CTD associated ILD. And this we are celebrating on the occasion of the centenary birth anniversary of our beloved founder, late Sri Ramaiah sir. We are grateful to him for creating this opportunity for all of us to conduct this CME program. All the departments are involved in this whole year conducting different kinds of CME programs. And interstitial lung disease is close to my heart because Indian Chest Society launched this ILD program way back in 2012. And it sent out an invitation for all the pulmonologists of India to be a part of this registry. And this was not existing earlier at all. And we were fortunate enough to participate. From 2000 up to 2015, we enrolled cases, and it was like MDD, multidisciplinary discussion, that is part of ILD. And we were in association with Professor Raghu, who is an authority on interstitial lung disease, and pulmonologists and radiologists and rheumatologists also may be aware of it. And we used to send our case scenarios to a center in Jaipur, and from there they used to send the case scenarios to USA, that is Seattle, Washington University, and only if they approve that whatever is the diagnosis from our side, and those cases got enrolled in the registry. And we are proud to say that our radiology department played an important role in this our participation, because we depend on radiologists for diagnosis of interstitial lung disease. Basically, it is based on HRCT imaging, all of you know that. And our radiology department were very cooperative, and with their help, we could enroll around 27 patients, and all the cases got accepted. That means that the interpretation of the CT findings from our center was equally good compared to international standards. So I'm thankful to radiology department for that. I use this opportunity to thank the radiology department to tell briefly about interstitial lung disease. As Dr. Prasanna Kumar has already told, it's a heterogeneous group of acute and chronic diffuse lung diseases of known or unknown cause. Other terminology for ILD is DPLD, that is diffuse pulmonary lung disease. And for some cases, we are able to find out the cause. So that means it is known etiology. And for majority of the cases, we are not able to pinpoint exactly what exactly has caused this ILD, that we call it as unknown. There are different groups of, there is more than 200 varieties of ILDs have been described. And what is the commonest finding what we get is IPF. So initially we were happy with the diagnosis of IPF, but now the awareness has increased. It used to be a rare disease way back in 2012. Over the period of years, we used to get only, the numbers will be in less than 50 like that. But now every other week, I was told Dr. Tanil Gupta sees almost 5 to 6 cases per week. And we are also seeing good number of cases. And whenever we get a case of ILD, we must always look for underlying connective tissue disease. Guideline says that you should not be happy. Even if the clinical radiological picture is IPF, we have to look for underlying CTD. So CTD, even though there is no clinical manifestation, CTDs can present as ILD to start with. Then when we start investigating, we can pick up connective tissue disease. So initial diagnosis, supposing if we say that it is IPF and ANA profile is negative, then we should not be happy with that. When the patient comes for follow-up, we must always look for underlying CTD features. So diagnosis of ILD basically depends on taking detailed clinical history and clinical examination findings. So history should include everything, like what are the main symptoms. Basically, they will come with cough and breathlessness. And along with that, other symptoms related to CTD. Patients may not come out with symptoms of CTD, but the clinician should be aware what questions need to be asked to pick up a diagnosis of underlying CTD. And anything patient tells, any symptom, we should not neglect it. That might lead us to an underlying CTD. Few months back, they must have had some joint pain. We just brush it aside that it could be just an osteoarthritis. That should not be done. So detailed history has to be taken, and environmental and occupational history also is very important, not the present occupation. Past history, chronology of occupation also is very important. We all know that pneumoconiosis can present as ILD. So history taking is very important, and the gold standard is to pick up a case of ILD after clinical examination to do HRCT. We all know that. And there is a big list of investigations. To pick up CTD, we have to look for INA profile, and if you are ANA profile, and you have to look for rheumatoid arthritis as well. Connective tissue disease, rheumatoid arthritis is the commonest cause for ILD, and it can present in various forms. When the CT film goes to the radiology department, they will just say that it is suggestive of ILD. They will not be able to tell what is the underlying cause for ILD. So it depends on the clinician to pick up a case of CTD ILD, and 15% of ILD cases are caused by connective tissue disease. And we have organized this CME program. We have organized this program with didactic lectures and case-based scenarios of connective tissue diseases. And we have external speakers, Dr. Tanil Gupta. I came to know that he did his MD radiology from M.S.Ramaiah Medical College. And now he is a senior consultant and radiologist in Narayana Health Teleradiology Department. and he is part of MDT, that is multidisciplinary discussion. I told that ILD always involves multidisciplinary discussion involving pulmonologists, radiologists, and pathologists. Now for CTD, we include rheumatologists as well. So we have Dr. Harshini, and she has done MD General Medicine and postdoctoral fellowship in clinical immunology and rheumatology, and she's a consultant in Spur Super Specialty Hospital. And we have also in-house faculty, Dr. Karthik. Welcome, Dr. Karthik. He has done MD Pediatrics and fellowship in pediatric rheumatology. And Dr. Bharat Chapriya, who is an assistant professor in pulmonary and critical care medicine. And I welcome all of you for today's CME program. Hope you enjoy this program. Thank you, Madam.
Thank you, madam. Thank you for that energetic opening speech. May I request everyone to raise the Ramaiah answer. Thank you. Now I invite Dr. Kanjivai madam for the inauguration by watering the plant.
Everybody come.
Thank you. So, ladies and gentlemen, please allow me to read today's agenda for the day. We have a series of 6 sessions with 3 important, very interesting case discussions and 2 expert speakers of didactic lectures. And there is one postgraduate quiz that is conducted by our Professor Dr. K. Shivswamy sir from Department of Dermatology. So, okay, now without further delay, I now request, I invite Dr. Manjunath HK, Faculty of Respiratory Medicine, to present his first case discussion.
To participate, my
So our guest speakers, Dr. Karnish Gupta and Dr. Ramshini, will be moderating the session and also leading the session. Thank you. If there is any questions, please raise your hands and please use mic to ask any question. Thank you so much.
Good morning. So I'll be discussing case number 1.
Back city.
Okay, case number 1. She is a 29-year-old female. She presented to us in 2018. She didn't have any comorbidities. She was from Bangalore, homemaker by profession. She was a homemaker by profession. She came with complaints of cough, which was non-productive since 4 months, exertional breathlessness since 4 months, tightness of the skin predominantly over the face and the neck, and difficulty in opening mouth since 4 months. She also complained of bluish discoloration of fingertips noticed since 4 months. It was worsened on exposure to cold environment. No history of joint pains, no history of stiffness of joint or swollen joints or fever. No history of dysphagia. No history of orthopnea or pain. So she was married with one child of age 11 years and married with one child of 11 years, and second one was stillbirth, which was recently, that was in 2011, at it was around 8 months of gestation. And menstrual cycles was regular, normal flow for 3 to 4 days every 28 days. Personal history: diet was mixed, appetite good, sleep disturbed due to cough and breathlessness, bowel and bladder is normal, otherwise no addictive habits. Vitals, it was essentially normal except for the saturation, which was borderline like 2% on room air. And upon examination, pallor was present, mouth opening was restricted, it was 2 fingers. At the time of examination, there was no Raynaud's phenomena. Sclerodactyly was present, that is, thickening of the and swollen fingers. And stellate scars was present at the fingertips. Puckering of the skin was present. There was no calcinosis, no telangiectasia. And upon respiratory system examination, there was bilateral clefts for infrascapular area and interscapular area. Anybody can tell me what is this? Except dermatitis. sclerotactile. Okay. This. So I just told you certain things. Digital ulcer and scars. So note the name.
Whenever a patient comes to you with a history of cough, breathlessness, because of skin tightening, so usually you should look into all this finding. And the important thing is just take to look at the skin thickness, and skin tightness. So mainly, that's one in involvement that is mainly the sclerotactile is the one thing where you can see that the digits are almost tapered and there is high bone skin. The second thing is that any kind of sclerosis, which is proximal to metacarpophalangeal joints or metatarsalophalangeal joint, that we just need to know. And third thing is you need to know about the one is Raynaud's phenomenon, which do occur. The patient usually comes. Sometimes when patient comes to you, you may not be able to demonstrate in your office or in your clinic. But mainly patient will give history of kind of following cold exposure, they will have discoloration of the fingers. That is one thing. And one more thing is the scars, especially the digital pitted scars. So that usually indicate that patient had some kind of vascular changes that lead to pitted scars.
Thank you, sir.
And other features of systemic sclerosis, usually you should look into. Like other cutaneous manifestation, but okay, anyway, this patient did not have much.
She had some bleeding in the photos, the some photos. Treatment and reduced. So this is a stellate scar. Okay. So upon presentation, these were the investigations done outside. And she was anemic with hemoglobin 8.6. Otherwise, CBC was okay, and the serum creatinine 0.72. Elastin was normal. HIV, HB, CGLC was non-reactive. ANA IF was done. It was 3+. And 2D echo was done. There was no PAH in that. And variant swallow was done. So it was normal. So what is the diagnosis? Yeah. Okay. So the dermatology department, they did the skin biopsy and it showed the features were consistent with systemic sclerosis. Then PFT was done. So PFT showed moderate restriction. See, FE1 by FBC was 92% and FTC was 51%. So like it was showing like moderate to severe restriction. So DLCO was done. So in that the PLCO was 3.28, normally 7.34. So it was 45%. So like moderate diffusion effect was there. So then, during the course of the evaluation, CT was done. So like Anup sir will be telling about the CT.
First, I would like to thank the Department of Respiratory Medicine, Dr. Gayatri, Dr. Pragati, Dr. Prasanna to invite me here for this talk on a home ground. With this much detailed clinical history, the job of a radiologist becomes very, very easier. Otherwise, without clinical history, as ma'am said, that we'll be just thinking of an ILD, what type of ILD becomes sometimes challenging for us as radiologists. So we'll try to analyze what we are seeing in this image. As radiologists, what we try to do is we try to clarify the patterns, where the disease is located, summarizing them, and then coming to a conclusion or a diagnosis, further diagnosis. So what we see here, there is some tubular bronchiectasis in the middle lobe, similar in the regular, and similar tubular bronchiectasis in bilateral lower lobes. So middle lobes are involved, regular and bilateral lower lobes. Surrounding which there are a lot of areas of blood and interstitial bleeding in bilateral lobes. Now, this disease pattern, all these features are present both in the central part of the nerve and in the periphery of the nerve. So, what we are dealing with is we are dealing with a fibrous in ILD, which has got an acute subacute component because there is ground glass opacities and interstitial bleeding. It is both central and peripheral in location. Upper lobes and lower lobes are also both are involved. So if we keep this all in mind, that we are dealing with a subacute interstitial lung disease which has progressed at a fibrosing early ILD and both central and peripheral pattern, then we can move to the next one. Perfect. Further coming down in the next sections, similar tubular traction bronchiectasis in bilateral lower lobes, middle lobe, and lingular, and similar ground glass opacities in interstitial thickening, which is both central and peripheral in nature. Till now, we have not seen any honeycombing till now. Here, what we see is there are a few tiny cysts in the periphery of middle lobe and lingular, and no other honeycombing as such present. Coming to the lung basins, so what we do see here is that there is traction dilation of bronchi in the periphery, some ground glass opacities, interstitial thickening, and some cysts in the middle lobe and lingular. Okay. So summarizing all these findings that the disease is present in the upper lobes and lower lobes, it's central and peripheral with traction dilation of bronchi and very minimal or negligible honeycombing in these images which are present here. I would like to put this as a non-UIP pattern because the disease is central and it's not acute disease. Now, when I say a non-UIP pattern, according to the new classification of radiology, this would fit into an alternate diagnosis. When we say alternate diagnosis, there are a few things which come to our mind when I have this type of listening presentation, which is either it can be a CT-related ILD, or sometimes it can be post-infection. But this is not the picture of a post-infection, so we're dealing with a CT-related ILD. Three other features which I'm seeing is that there is dilatation of the esophagus. Few of the slides above show that this esophagus has got some food material inside it. So these features, along with the CT ILD, is one of the classical features of systemic sclerosis, where you get dilatation of the esophagus with hold up of food material or contrast sometimes. These patients sometimes also present with pulmonary hypertension because of the features. Next. So CT-related ILD in terms of systemic sclerosis, SSC-related ILD, has got basically two types of patterns when they present. NSIP pattern, which is initially cellular NSIP, later on becomes a fibrotic NSIP pattern. And the second pattern is a UIP pattern. Okay. So patient can present both ways, so NSIP pattern and a UIP pattern. The previous case was a fibrotic NSIP pattern. This is, there are few features when it presents as both UIP pattern and NSIP pattern. There are 4 signs which every radiologist and even pulmonologist should look at when we have a series of images. First is the anterior upper lobe sign, where the upper lobe anterior segment is significantly involved. This is, you can see, appreciated on a sagittal image. But a lot of interstitial thickening throughout the lungs with ground glass opacities. Minimal honeycombing has started just adjacent to the diaphragm. On a coronal image, we usually get multiple times a straight edge sign where the upper lobes are spared and the lower lobes are significantly involved. So it gives you on coronal image a straight edge sign. For this, as the previous patient had, a dilated esophagus with an air fluid level, which relates to Morgan disorder. And fourth is exuberant honeycombing. So this is different from a typical UIT honeycombing. This is exuberant honeycombing. There will be extensive honeycombing, and all four, both cardiophrenic angles and osteophrenic angles will be involved. So this is known as a four corner sign. So anti-upper lobe sign, straight edge sign, four corner sign, exuberant honeycombing, and dilated esophagus. Another case of systemic sclerosis related CT20 diabetes, which we had at our center, and this presented as an NSI pattern. So what we see here is the ground glass opacities, subinterstitial thickening, both central and peripheral in nature, tubular bronchiectasis, which starts from the center and goes up to the periphery, not much of honeycombing. Along with that, we can notice here the dilated esophagus, which has got an air fluid level. This patient also had features of pulmonary hypertension. The pulmonary artery is dilated more than the aorta, and this is also one of the features of systemic sclerosis related IIT.
Thank you, sir. So after this, so the diagnosis of systemic sclerosis ILD was Dr. Ashwin Hassan saw the case, and she will be telling the management of the case.
Good morning, everyone. First of all, I would like to thank Department of Pulmonology, Dr. Gayatri ma'am, Dr. Pragati, for inviting me here for this event today. And it's a pleasure to have a discussion on connective tissue diseases. So in this particular case, I had seen her first in 2018 when Dr. Manjunath had referred this patient to me. And predominantly this patient had presented with pulmonary complaints, but she had neglected most of the other findings which she had. So on a detailed clinical examination, I could make out that she had significant skin changes in the form of sclerodactyly, and she had skin thickening almost all over her body. In the face, her mouth opening was reduced, neck, trunk region, extremities, everywhere there was significant amount of skin thickening, and we do follow certain scoring systems for exactly evaluating this particular skin thickness also. So it is called as modified Rodnan skin score. This patient on a scale of 0 to 4 had almost grade 3 thickening when I had examined her in the initial phase. And on clinical examination, though she did not have an evident Raynaud's phenomenon, she had features suggestive of vascular insufficiency in the form of digital tip ulcers, stellate scars, which were giving a clear clue that Raynaud's phenomenon had been going on for quite some time. And on very detailed history taking, she also had some features suggestive of gastroesophageal reflux disease. So she had almost all features to classify as a typical systemic sclerosis. Okay, so with symptoms of cough and dyspnea, with typical features of Raynaud's phenomenon, skin tightening on clinical examination, ANA being positive, she had 3+ score spectral pattern on her immunofluorescence, and HRCT was mostly suggestive of a mixed pattern as sir discussed right now, but there were few features of UIP in the form of honeycombing and all that. With all these features, she was diagnosed to have a systemic sclerosis with interstitial lung disease. So clinical clues, as we already mentioned, few of the clues we have discussed, but we also need to look for certain other features, like patients with systemic sclerosis will have significant pigmentary changes in the form of hypopigmentation of the skin with perifollicular sparing, which causes typical salt and pepper pigmentation of the skin. This is seen in many patients of systemic sclerosis. Because of the skin tightening seen around the oral aperture, we see a typical feature called as radial furrowing and reduced opening of mouth. Then Raynaud's phenomenon, which was evident in this patient also, and digital tip lesions. So these are all few clinical clues which we will be able to pick up, because most of the patients will keep ignoring these symptoms and they will present to the clinician only when they start developing the symptoms like cough and dyspnea, because those are the ones who start bothering their day-to-day activities. So talking about the types of systemic sclerosis, we have basically two broad categories: diffuse systemic sclerosis and limited systemic sclerosis. Clinically, it is important to differentiate these two because there are certain features which are predominant in the diffuse type and certain features which are predominant in the limited type. So diffuse type of sclerosis involves skin thickening on most of the regions of the body, whereas limited systemic sclerosis will have thickening of skin only in the distal extremities, face and neck. And it is important to differentiate because the interstitial lung involvement is mostly seen in diffuse systemic sclerosis, whereas limited type, we see more of pulmonary vascular involvement. So those patients with limited scleroderma presenting with exertional breathlessness, we are more worried about pulmonary hypertension rather than the interstitial lung disease. And definitely there are certain differences in the antibodies which are positive in these patients. So in diffuse type, we see something called as anti-SEL70 positivity, and in the limited type we see something called as anti-centromere positivity. I think ANA profile we are having a detailed discussion subsequently, so I will not go into the detail of these antibodies as such. Certain antibodies again carry a high risk for interstitial lung disease. So we do a whole lot of profile when the ANA profile, we look at multiple antibodies in the immunoblot, but only few antibodies, like as I mentioned, anti-SEL70 carries a high risk of interstitial lung disease, and few other antibodies which we see in overlap connective tissue disease also carry a high risk. So whenever a patient presents with a patient with systemic sclerosis presenting with only skin features, treatment would be different. A patient with systemic sclerosis having an interstitial lung disease, definitely treatment would be much more aggressive, because ILD as such marks a high risk of morbidity and there is increased risk of mortality. ILD and pulmonary hypertension are the two complications which carry very high risk of mortality in patients with systemic sclerosis, and they need to be addressed very aggressively. So on HRCT, we have to look at the type of ILD, extent of involvement, acute and chronic changes, need for ruling out infective etiologies becomes very important. All these has been discussed by sir, I will not go into it. We have to document baseline pulmonary function test. We have to look at their FEV1, FVC values, because subsequent monitoring will mostly depend on pulmonary function test. We are not going to repeat the HRCT once in every 3 months or 6 months, but PFT has to be repeated on a routine basis, and that is the one which is going to tell us whether the treatment is being effective, whether the patient is stable or the interstitial lung disease is progressing clinically. PFT is very important. And also we have to look for features suggestive of other organ involvement. As I mentioned, they might have a coexistent pulmonary hypertension. Some patients will have pulmonary vasculitis. Scleroderma patients as such can have peripheral vasculitis features. So if at all there are other manifestations, then again treatment has to be much more aggressive. HRCT wise, broadly in systemic sclerosis as such, we say if at all there is more than 20% of lung involvement, it is classified as extensive disease. And again, the FVC values less than 70% of predicted, that also classifies as an extensive disease. So this is where we are concerned, because the type of immunosuppression which we choose for the patient depends on whether the involvement is limited or whether the involvement is extensive. So I have put up a broad framework which gives us an overall idea of how to manage when a patient presents with a patient of systemic sclerosis presents with ILD. So as I mentioned, we look at HRCT, we look at the pulmonary function tests, and we formulate depending on limit whether the involvement is limited or extensive, whether the patient has other extra pulmonary manifestations and all that. We plan their immunosuppression according to that. It can, of late, we are trying to see whether a combination of immunosuppression along with antifibrotic therapy works better for this patient, or if it is just predominant ground glass opacities which marks acute changes, we would prefer to choose only immunosuppression. But if there are a lot of fibrotic features also, then we would probably start with a combination of immunosuppression along with antifibrotic therapy. And on subsequent monitoring, if at all the patient continues to be clinically stable, and if they're clinically stable, then we would like to monitor the PFT once in every 6 months. If the PFT also is not showing significant changes, then we continue to maintain on the same immunosuppression which we have started in the initial phase. But if at all if clinically patient is progressing, or on monitoring, if the PFT shows that the restrictive lung disease is going on worsening, then we would like to consider whether the patient needs a switch of immunosuppression. Like if we have started the patient on azathioprine, we may consider to switch to mycophenolate, or if at all it is progressing very fast, we may consider medications like cyclophosphamide. And of late, we are also using biologics in treatment of systemic sclerosis. So the step-up therapy is considered in patients who are progressing, but if they remain stable, we will maintain them on the same immunosuppression at least for a period of 1 or 2 years, and then consider whether we can start tapering the dosage of medications. Okay, so discussing about different types of immunosuppression, as I mentioned, the medications which we would consider in the initial phase would be azathioprine and mycophenolate. These are the first choice drugs for treatment of interstitial lung disease and systemic sclerosis. If at all the patient has severe disease, then we would probably consider giving IV medications like cyclophosphamide and biologic injections like rituximab. Stem cell transplant has also been tried in patients with systemic sclerosis ILD, but as of now, we are not using it on a routine basis. So if at all the patients are able to attain remission, then we plan to continue maintenance with the same medications. But if there is failure of treatment, then we have to step up therapy to the next level of medications. And in severe cases who are progressively worsening, there may be a role of lung transplantation also. As I was talking earlier about the role of antifibrotics, because we know that systemic sclerosis is mainly a disease wherein there is a lot of fibrosis going on in the skin as well as in the lungs. So nintedanib is one of the drugs which was approved in treatment of IPF initially, and subsequently it was also extrapolated for usage in systemic sclerosis. So various studies, especially a particular trial called as a census trial, looked at the role of nintedanib in patients with systemic sclerosis as such. And when nintedanib was administered in patients with systemic sclerosis, both in combination with immunosuppression and without immunosuppression, it proved to be better than placebo in halting the progression of disease further. So definitely it has a role. If at all patients have a lot of fibrosis, then we would like to start the patient on the antifibrotic along with immunosuppression, whatever the patient is already on. So significant reduction in FVC was seen in patients who had progressive disease despite 24 months of immunosuppression after they were started on antifibrotic therapy. The effect of antifibrotic therapy is more pronounced in UIP pattern of ILD than the other patterns. However, diarrhea and transaminitis are the common adverse events which have led to discontinuation of nintedanib in most of the patients. So with this, I would like to conclude the discussion about how we approach a patient with systemic sclerosis ILD and how we manage. In this particular patient whom we have been managing for last 4 years, I would like to say that I started her initially on azathioprine at a dosage of 2 milligrams per kg body weight, along with 0.5 milligrams per kg weight of steroids. And steroids were tapered over a period of next 3 to 6 months. Subsequently, she was maintained on azathioprine. I had been sending her back to the pulmonology department here once in every 6 months for her for monitoring of her pulmonary function tests. She has remained stable. After 2 years of stable disease, I have tapered her azathioprine dosage also. Right now, she is on 50 milligrams of azathioprine per day. She is not requiring any steroids. Even her skin disease has come under very good control. The initial tightening which was there has come down. Her Raynaud's phenomenon is under control. She is only on 10 milligrams of Nicardia retard per day. And she was not given any antifibrotic therapy. The recent CT scan was repeated about 6 months ago. The ground glass opacities have completely vanished, but the fibrotic changes still remain. Clinically, she remains stable. She is able to manage her day-to-day activities 100% without any discomfort at all. And I have last seen her about 15 days ago, and she continues to do very well. So the role of immunosuppression in these patients is really important because otherwise they will gradually progress, and the 5-year mortality itself can be as high as 50 to 60% if at all they are not treated on time. Thank you.
Thank you, Rashmi. So, any doubts regarding the systemic sclerosis?
Just want to add back to that. Yes. That the census trail, we are part of it.
Oh, okay, ma'am. I was not
We
aware.
have one male patient
Okay.
diagnosed with systemic sclerosis, and his main presentation was not skin lesions at all. He presented only with dry cough.
Okay.
And for the dry cough, when HRCT was done, it showed a basal minimal ILD features.
Okay.
And ANA profile was done, and further workup showed that he is having systemic sclerosis.
Okay.
And he is on my MMF, and he is on Nintedanib.
Okay.
So Nintedanib, I think he is into the trial almost 5 years now. He is doing very well. So I feel that this patient also should be started on Nintedanib because ILD features have already set in.
Yes.
It will definitely add to further progression of, it will prevent further progression of underlying ILD. Thank you.
So this is the one. Actually, I'm so proud that we have been part of this trial because this is the standard trial which is everyone quotes all over the world to give any evidence as far as antifibrotic therapy and immunosuppression is concerned in ILD as far as systemic sclerosis is concerned. So.
Yes, I wanted to add on that that CT has connective tissue pattern, as you suggested, that fibrotic NSIP pattern. I don't know how much that Nintedanib or Pirfenidone, like I would like to differ. They say if honeycombing sets in, traction bronchitis sets in, that's an indication. But it's good to know that if there is a chance of fibro like this drugs are there, then it's
Yes.
And one more point that examination of skin is very important. We just skip on that and we don't examine properly. So that is one more important point we learned from this case.
Swami, you want to talk about capillaroscopy? You haven't instructed.
Yes. Much we do because many a times we do that we have the dermoscope and we do the capillaroscopy, and that is important part of diagnosis. And second thing I just wanted to highlight on mainly the clinical features. So patient may come to you with cough or something if you are sitting in any other period, and mainly we have to look at the skin manifestation. That is one important thing. So because almost 3 of the 4 criteria of this one belongs to dermatology thing. One is the proximal sclerosis, proximal to metacarpophalangeal and metatarsophalangeal joint. That is one thing which is a major criteria. That itself will tell you if patient is having systemic sclerosis. And other minor criteria of which the sclerodactyly and digital pitted scars. So, and third one is again the bibasilar lung fibrosis, but of the 3, the 2 are there. So, the dermatological findings are very much important and should be appreciated at the earliest stage. In capillaroscopy, we do that mainly using dermoscopy, where here you can just get to see what is called as a hairpin changes. So usually there will be afferent arterioles, and usually suddenly it drops down. So that is one typical picture what you see in case of systemic sclerosis.
Can I add on the capillaroscopy?
Yeah. Thank you.
So the nail-fold capillaroscopy has evolved a lot in rheumatology field as such. We are using it on a day-to-day basis actually, wherein we evident cases like this, wherein we can pick up the skin findings and digital scars and all that, it may not carry much importance. But if at all patients have presented in the initial phase, wherein they are only complaining of Raynaud's phenomenon once in a while, it is not very evident, we are not seeing any digital scars and all that, we subject most of these patients to capillaroscopy. And we do see that we start seeing the early scleroderma changes on capillaroscopy. Very evidently, we can pick up the changes, and over a period of time, we have followed up, like especially when I was working in CMC, we have followed up these patients and we have published various studies on role of capillaroscopy in systemic sclerosis, where they have gradually evolved. The skin changes have started to appear maybe about 3 or 6 months later. Many patients have manifested with pulmonary hypertension because we see that the capillaroscopy changes correlate with the onset of pulmonary hypertension later on, because both of them are related to vascular pathology. So we advise patients for a regular 3-monthly follow-up once we start picking up the changes on nail fold capillaroscopy. However, if capillaroscopy is completely normal, we can definitely ignore it for that point of time. But if we start seeing, and we also have certain gradings for capillaroscopy changes, early changes, active changes, chronic changes. So we see the reduction in the capillary density, the capillary dropouts. We see a lot of telangiectasias and the hemorrhages on the capillaroscopy. So there are a lot of findings. So we characterize it accordingly as what could be seen in the early phase, what is seen in late phase, and that is it has evolved as far as rheumatology practice is concerned. So at least in Bangalore, I can say about 3 to 4 centers have started doing nail fold capillaroscopy as of now on a routine basis. But so far it was not, it was only there in big institutes like SGPGI and CMC Vellore.
Thank you, Dr. Manjula. That was a very interesting case discussion. Without much delay, I would move on to the next session. The most anticipated quiz for the postgraduates. The quiz master is our Jay Shisomasa from the dermatology. Please take on. Over to you, sir. So, our postgraduates, please raise the hand to answer the quiz, and the mic will be given to the person who is raising the hand first. Okay, and I'm sure you'll be getting some chocolates. Yeah, for the winners. Thank you so much.
Already the first question is.
It's like for a second it got split clear.
So the dermatologist, I can do this, I can look at questions for dermatology residents, but this is a general forum where it's difficult for me to set questions because some of the things I also may not be knowing much because in your specialty, but somehow I try to make it very simple. And there are some exciting phrases what Dr. Adam was telling. So you can get even friends and even chocolates also, I think. So it is not kind of very formal quiz, it is just an informal quiz. You can just raise your hands and you can just answer. Yeah, it is Erasmus syndrome. You might be knowing at least, huh? Yeah, right. Didn't expect from a dermatologist to get that. That's very good. So this is actually systemic sclerosis secondary to silica exposure. So may or may not be associated with silicosis. Next. So this is a 25-year-old male presented with is a case of scleroderma presented with soreness in the mouth. So this is a radiological picture of the mouth showing the teeth. So can you just find out what size it is and what are the changes? The radial is again, radial is previous. Anybody answer?
Because of the name of the site, but there's increased dental enamel space, increase in distance between those.
You will be getting prize only if you answer over the side. Others are okay. So this is a periodontal membrane widening. So usually seen as systemic sclerosis. So this is called Stapner site. This, of course, you know, this is periodontitis. So that is physical sclerosis. And this one, stellate scars. And this one, or part of dislocation, reflex disease. So the question is, what medication used to treat for the whatever digital fitted scars will aggravate the dislocation discotyledon? That's the question. Anybody can tell.
The choice of drugs.
No, they can just tell only the main group of drugs. So used to treat the Raynaud's phenomena or whatever digital scars. And good. Mainly the calcium channel blockers, so that it will give, usually that will worsen the esophageal dysmotility or reflex. So this is mainly for medicine postgraduates and chest medicine. You have to answer both to get one hematological and one cardiac manifestation indicating impending renal failure in the case of systemic sclerosis. This is given in your Harrison's only. Because these are the two important things you should look into. So that the patient may go for renal failure.
Anemia.
It should be more specific. What type of anemia?
Anemia, chronic disease, and pulmonary hypertension.
Cardiac manifestation.
PCA. Digestive colic.
No. Nobody? So you get to see helmet cells. Huh?
What's the sense?
Hemolytic helmet cells. So hemolytic uremic syndrome usually. Hemolytic uremic syndrome is one thing where you can tell the patient to go for renal failure. Then cardiac manifestation, pericardial effusion. So these are the two impending signs which will indicate the patient will go for renal failure. So first, this is a violaceous dermatologist will tell you, violaceous macular edema with kind of edema of the eyelids. Classical of Heliotrope, classical of dermatomyositis. So this one, dermatologist. No, wrong, because my question is not at all. Then we can see some kind of violaceous erythematosus papules on the nipples. So this is called Watkins papules. So usually seen under extensor aspects. My question is, what is inverse Watkins papule? Where do you see? Palms. Very good. So I wanted others to answer, not that customers. Okay, no problem. So usually the palms are the one where you see what is called an inverse Watkins papule. This theoretical answer. Which anti-tubercular drug is known to cause dermatomyositis? Very good. SODS can cause. Give me a quick applause. I can cause. Doctor?
Yes.
Doctor, you are from? Radiology.
Maybe it is part of the neat question.
So this is a 35-year-old female presented with history of progressive stiffness of finger and tightening of skin over chest and face of 2 years duration. An inquiry, she has some existential dyspnea also and difficulty in swallowing with cerebral regurgitation. So this, you know, what is the diagnosis? So these are the type of pigmentation usually you do get, salt and pepper pigmentation as well as distal pitted scars. So what changes do you expect? Radiologist can tell. What are the early changes in systemic sclerosis? Pardon? Good. So bivascular reticular opacity, usually reticular shadows in the lower lobe. So that is classical of systemic sclerosis. Give him the chocolate.
Radiology, they should know.
Actually, that others counterpart
But,
should tell them. If it's a radiology question, I think that other department research should tell. This one, apart radiologist, can you just tell what is it? Pardon? What is more evident here apart from that? So you can see two important things. One is in the tip, you can see one thing, and second thing you can see in front of hyperdense lesions. Yeah, so this is good calcinosis cutis and associated with osteoporosis. So which condition, which connective tissue disorder is seen in this one? Combination of both osteoporosis as well as calcinosis cutis. Yeah, it's in. So my next question is what? So in which condition you see popcorn calcification for radiologists? Which connective tissue disorder? You see popcorn calcification. Pardon?
Sarcoid.
No. Connective tissue disorder. No. Who answered? The leftover is the dermatomyositis. Huh? So dermatomyositis is the correct answer. So what kind of, okay. So bone resorption with calcinosis is typically seen in systemic sclerosis. This can anybody make diagnosis other than dermatology? What are the cutaneous finding and what's the radiological finding? So this girl presented with sort of thickened and sclerosed skin, especially on the limbs, mainly the upper limb. You can see some changes in the bone also.
None of us have seen this, please answer this.
The dermatologist. This is more of kind of a linear morphia. The morphia profound also, but she has little extensive vision. And what is the radiological change we get? Usually the candle wax gripping. So that is typical of malaristosis.
You have seen this case?
Yeah. Straight from long back. Yes. Name an anti-PGF antibody used in the treatment of scleroderma. Anti-PGF beta antibody. Just consider PGs can take a chance. It is Ressolimumab. So it's an anti-PGF. This one, can anybody make query this? Pardon? SLE, okay. The next question is, can you just tell what it is? So what is it called? Lupus band test. Oh. Want others to answer. So this is typical lupus band test where you see granular deposits mainly in the dermal junction. No chocolate for it. SLA at this, if you see immunofluorescence, it's a lupus band test. So just you will get this one. How many? What are the sites you should take for immunofluorescence test? This one. These are the training.
These sites, exposed involves skin, non-exposed involves yeah.
Okay, correctly you will get chocolate. Not formal.
Involved exposed skin, non-exposed involved skin, non-exposed non-exposed.
Which area the non-exposed and involved skin?
In respect to the forearm and back is considered non-exposed non.
So if you see a non-exposed uninvolved skin, and especially the buttocks, if you see this positive, usually it is correlates with it. But the patient will go for LE. And you have to look for which other system for other species. If you see positive lupus band test, which system or internal involvement, organ involvement usually should look for? Renal involvement, correct. So this is just anyway, Dr. Karthik will go to tell next. So this is just an immunofluorescence pattern. So it's any immunofluorescence. You can just tell what is this pattern, not dermatologist, not this pattern, and which condition is. What pattern is this, and in which connective tissue disorder you see this pattern typically? Okay. Yeah, very good. Nuclear pattern. Very good. So which condition you see? Which connective tissue disorder? UCTs. So tell at least mainly the 3-4 connective tissue disorder. That's it. Huh? Correct. You get in scleroderma. So the last question, anyway. Sorry, it's not a fungus, it is the protozoa. So which protozoa? Dermatologists also can take part in this. Which protozoas used as substrate for immunofluorescence, any immunofluorescence? You should name that protozoa. not fungus, it is protozoa. It is Lithidia lucilea. That is a protozoa. And what the expected developer is to answer. Oh.
Thank you, sir. Thank you for the participation. Thank you, and congratulations for the winners. For the delay of the schedule, we just move on to the second case discussion. I now invite Dr. Tanisha Salim, Assistant Professor of Department of Respiratory Medicine, for the second session of for the second case discussion. I also invite Dr. Gupta sir and Dr. Ashwini to moderate the session and lead the discussion. Thank you.
Morning, everyone. Morning, everyone. I'll be presenting an interesting case of connective tissue disease which we've come across. Here is a 66-year-old 66-year-old female patient, elderly, who's presented to surgery OPD first on 1st of July 2021 with complaints of pain abdomen, nausea since 3 months, and itchy regions over the scalp, face, thighs, shoulders since 3 months, swelling of both eyelids and generalized weakness since 2 months, difficulty in getting up from the floor. So following which there was an incidental past history that she had moderate COVID-19 pneumonia 3 months back, for which she has been hospitalized for a week, and she was put on oxygen and treated with the moderate protocol remdesivir. Known case of diabetes mellitus and hypertension on medication. Patient was advised for dermatology and neurology reference for the above mentioned complaints. For respiratory medicine per se, she came for the sake of post-COVID status. So with on examination, there was an elderly female who was conscious, cooperative, oriented to time, place, person, and she was moderately built. Vitals, pulse rate was 91 beats per minute, respiratory rate 18 cycles, a blood pressure of 130 by 80, and saturation was also normal, 95% normal. So this was the patient. On general examination, she had erythema and edema in the periorbital area. Hyperpigmented patches were noted on the forehead. Also, there were hyperpigmented patches and erosions over the nape of the neck, upper back, and bilateral shoulders. There was hyperpigmented patches similarly seen on the scalp and also on the abdomen. And on the scalp, there was a biopsy also taken. This is the hands and the upper thighs also showed erythema and hyperpigmented patches. There was cutaneous ulcerations which were noted over the knee and in the gluteal area. Systemic examination, central nervous system examination, upper limb power was normal. Proximal muscle weakness was noted in both the lower limbs with power of 4 by 5. She had a waddling gait. There was no distal muscle weakness and reflexes, superficial and deep tendon were normal. Perabdomen was soft, non-distended. Tenderness was noted in the epigastric region and also in the hypochondriac region. Bowel sounds were heard. Other system examination was unremarkable. So moving on to the before the investigations, I would like Dr. Shivaswamy sir to give him any the cutaneous manifestation, any more inputs.
Usually, whenever we see any kind of skin manifestations like this with history of mild tiredness or weakness or difficulty in getting up from the sitting position, usually we think in terms of any connective tissue disorders. Of which the most important thing is here this patient presented with kind of periorbital edema and kind of mild erythema also. So if you closely observe, you can see you will make out what are called as telangiectasia, which are the slightly dilated vessels. So that any kind of erythema, telangiectasia involving mainly the eyelids with periorbital edema, you should think into along with history of weakness or getting up from difficulty in getting up from sitting position. Usually think in terms of dermatomyositis. This also we thought of one thing. Second thing is the other manifestation usually should look for. In any case of connective tissue disorders, as I said in case of scleroderma also, and even in SLE also, the first four criteria in the SLE also belong to dermatology department. That is the discoid rash, then oral ulcerations, photosensitive rash, and kind of malar rash. So similarly, in systemic sclerosis also, the first three belongs to us, dermatology department, and even in dermatomyositis also. So you have kind of heliotrope rash, and as I said, there are some kind of typical papules. Of course, in Indian skin, it's very difficult to make out any kind of Gauthren's papules, but in fair skin individual, you can make out. So these are kind of hyperpigmented to erythematous or violaceous papules with or without atrophy, with or without scaling, but usually with telangiectasia, that's what you see mainly at the knuckles. If this is there, usually you think in terms of a Gauthren's papule, usually you don't get to see in any other condition. Similarly, you have to look for any kind of erythema, or with telangiectasia or some kind of mild hyperkeratosis or telangiectasia, especially on the upper chest, which mainly the photosensitive area, then on the sides of the arms and even the upper back, which is called shawl sign. And sometimes you should look for any kind of erythema and hyperpigmentation in telangiectasia, mainly in the buttocks area, which is called a Holster's sign. So these are some of the things. Along with that, you should look for any kind of calcification, cutaneous calcification, where there is deposition of some kind of chalky material like, or sometimes then hyperkeratotic or thickened skin, especially at the sides of the finger. So these are the important manifestations patient can present with, and you should suspect a case of dermatomyositis along with kind of systemic symptoms.
Thank you, sir. So moving on to the investigation, she was subjected to the following investigations: her routine CBC, RFT, LFT, CBC, RFT, LFT, thyroid function test, serum electrolytes were normal. ESR was raised 42 mmHg. CRP 85 increased. Serum ferritin was 329 nanogram per ml. ECG and 2D echo was normal. Viral markers for HIV, HCV, and HBsAg were negative. Serum creatinine kinase was 1.99 normal. Serum LDH 323 normal. Serum creatinine phosphokinase total was 71. ANA profile and report were negative. ANCA report was negative. Myositis profile showed autoantibodies against MDA53+, which was positive in cases of 15 to 30% in dermatomyositis, and Mi2 alpha 2+, dermatomyositis is positive in case of 20% of cases. So she was subjected to upper GI endoscopy because her presenting complaints was to surgery OPD with pain, abdomen, and nausea, which showed a reflex esophagitis, gastric erosions, and duodenal scalloping was there, and the biopsy of the same revealed non-specific inflammation. Barium swallow was done, which showed normal study. Ultrasound abdomen and pelvis showed just cholelithiasis. HRCT lung showed multifocal ground glass attenuation with subpleural fibrotic bands and interstitial thickening in both upper and lower limbs, suggestive of a post-COVID infection. Dr. Tanuj will be able to tell us the findings.
This patient had COVID pneumonia 3 months ago, so this we need to keep in mind before reading the images of HRCT chest. So what we see here is that the middle lobes, the inula and bilateral lower lobes have got ground glass opacities, some areas of interstitial thickening, and in the periphery we can see areas of early consolidation of the picture. And when we go to the lung basis, there is some degree of fibrosis, reticular opacities, traction bronchiectasis in the middle lobe, and so traction bronchiectasis in the middle lobe. There, ground glass consolidations, atlectic and fibrotic tabs, and here ground glass opacities. So if clinical history is not given, and all these patterns are in the periphery of the lung, central part of the lung, are relatively spared. So it will be two definitions will come to our mind. if history is not given. One is post-COVID sequelae, and second is the CTD-related element. There will be an overlap in both the disease patterns, and we have seen multiple times that in post-COVID infection, all these ILDs have flared up significantly. So if there is an underlying CTD-related ILD, it will be flared up with post-COVID infection. A few features which are like here early consolidation and the patterns of organizing pneumonia in the right lower posterior segment in the lateral segment of upper lobe, posterior segment of the upper lobe. These areas are quite concerning for the organizing pneumonia. One of the features which dermatomyositis presents is either an organizing pneumonia type of pattern or an NSIP pattern. So this is not an NSIP pattern or not an UIP pattern. This is an OP pattern which can be in post-COVID infection sequelae versus CTD-related ILD, most probably dermatomyositis.
Thank you, sir. So moving on, the patient was subject to the nerve conduction study and electromyography because she had difficulty in getting up from the floor. Nerve conduction study, there was a demyelinating neuropathy in bilateral median nerve, which was suggestive of a carpal tunnel syndrome. But there was decreased common peroneal nerve compound muscle action potential amplitude. On electromyography, there was occasional positive sharp waves and fibrillation were seen as insertional activity in bilateral quadriceps. Few fasciculations were seen as spontaneous activity in the right quadriceps. Motor unit action potential was normal. So this was a skin biopsy of the scalp, which showed atrophic epidermis per se with absent red ridges. This vacuolar alteration of the basal keratinocytes and superficial dermis shows sparse lymphocytic infiltrate amidst the collagen bundles, probably suggestive of a dermatomyositis. So considering the clinical features and the investigation results, the case was diagnosed as clinically hypomyopathic dermatomyositis. So with this, she was started with a treatment of pulse IV steroid, methylprednisolone, 500 mg per day for 5 days, along with oral MMF, 500 mg twice a day. Patient had received 2 pulses of the steroids with mild improvement in the skin lesion and is on regular follow-up for the skin. Dr. Harshini, madam, will be able to tell us some issues.
Okay, so dermatomyositis as such, not all patients present with similar features. It is a wide spectrum of disease wherein we see certain patients presenting with only skin manifestations. On the other spectrum, we see patients presenting with just the muscle weakness without any skin manifestations at all. But most of them are in between with few features of skin lesions and some amount of muscle weakness, which is evident either clinically or we see elevation in the muscle enzymes, or we may be able to pick up certain findings on electromyography. If nothing is conclusive, we may have to do certain invasive procedures like muscle biopsy to get into a proper diagnosis of myositis. So, talking about dermatomyositis, sir has already discussed about the skin manifestations of dermatomyositis. So basically, a patient who presents with generalized weakness, where we are suspecting a dermatomyositis, there are multiple clinical clues to look for. So this is the typical heliotrope rash, the violaceous rashes which we see. We also see malar rash in patients with dermatomyositis, the Gordon's papules over the extensor aspect of the limbs. And as mentioned, it may not be evident in the Indian population. So the V sign and shawl sign, so I was talking about. So the V sign is typical erythematous lesions which are seen around the neck in the form of V. So this is called as the V sign. And over the neck and upper back, this is called as the shawl sign. So, and also we see, the sir was talking about telangiectasias over the skin. So typically we see what we call as periangular telangiectasias, which can be picked up very easily. And this is also one of the manifestations of dermatomyositis. And as rightly pointed out, calcinotic lesions. The calcinosis cutis is also one of the dermatological manifestations. So if at all the diagnosis in patients whom we are seeing for the first time, we will have to go into certain details of clinical examination to pick up these particular findings. As far as skin manifestations in dermatomyositis is concerned, there are at least 14 to 15 named signs as such, including the shawl sign and holster sign and everything. So there are a lot of things which we look at. Subsequently, coming to a diagnosis of dermatomyositis, we use a particular criteria called as Bohan and Peter criteria, which has been in use for many years now. So for a patient to be classified as dermatomyositis, compulsory finding is the typical rash which we see in dermatomyositis, and along with that, they need to have Along with that, they need to have certain other findings, either a clinical evidence of symmetric proximal muscle weakness. They need to have elevated muscle enzymes. So when we talk about muscle enzymes, we have to, it is not just the CPK and LDH, even SGOT and SGPT, with predominant SGOT elevation more than SGPT also is considered as elevation in the muscle enzyme. So there are 4 muscle enzymes which we look at, and elevation in these muscle enzymes is also one of the characteristic features of an active myositis. Electromyogram pattern, which is typical of myositis, there are certain features which are very characteristic of an inflammatory myositis. What was presented in this case is not very typical. The findings are vague. It is not very suggestive of an inflammatory myositis as such. And if none of these are very evident, then we have to go ahead with the invasive procedure, that is muscle biopsy. So muscle biopsy is a definitive investigation wherein we can typically pick up the features of myositis. So if at least 3 of these criteria along with the skin changes are present, then we call it as definite dermatomyositis. In this particular patient as such, though she had typical skin rashes, none of the other things were evident. She did have some amount of muscle weakness, but the muscle enzymes were normal. Electromyogram was not very classical of an inflammatory myositis. Muscle biopsy we could have probably done, but we had already done a skin biopsy and myositis profile, so that had made our diagnosis much more easier in this case. So talking about myositis profile, so after the myositis profile is being used over the last few years, the number of invasive procedure for muscle biopsy has actually come down. So a moment we have a suspicion of inflammatory myositis, we go ahead with something called as myositis profile. It is a huge profile, includes a lot of autoantibodies. And each of these antibodies is very important because they tell us what could be the possible clinical phenotype of the patient and what could be the possible prognosis of the patient. Certain antibodies carry a high risk for malignancy. Certain antibodies carry a high risk for internal organ manifestations in myositis. So that is where myositis profile has, taken the diagnosis of myositis to a better level. So I will not go into all the clinical phenotypes, but I would like to highlight that interstitial lung disease as such is more common in the subgroup of autoantibodies called as anti-synthetase antibodies. So this includes predominantly anti-Jo1, anti-PL7 and PL12. So all these 3 antibodies carry very high chance of a patient having interstitial lung disease as such. Especially anti-Jo1 is related to something called as sir was talking about a sign called mechanics hands. So somebody having anti-Jo1 positivity, myositis, mechanics hands, interstitial lung disease. So it all falls into one picture. Apart from the anti-synthetase group of antibodies, the second group of antibodies which carry high risk for interstitial pneumonia, especially rapidly progressive interstitial pneumonia, is seen in what we had in this particular patient, that is anti-MDA5 positivity. So usually this particular antibody called as MDA5, it marks a clinical a subtype of dermatomyositis called as clinically amyopathic or clinically hypomyopathic dermatomyositis, wherein the skin findings are very evident. Muscle weakness will not mean much, muscle enzymes are not elevated, but they carry high risk of rapidly progressive interstitial pneumonia. So as Dr. Tanuj was discussing, in this patient, is it all just post-COVID sequelae or we should be taking it as an interstitial lung disease? We have to be very careful about it. Also, to highlight that anti-MDA5 antibody or this clinical entity called as CADM carries high risk for malignancy. In this particular patient whom we have been discussing so far, the elderly age of onset of symptoms, the particular antibody positivity which she has got, the aggressive disease, rapidly worsening symptoms, and I don't think she has improved much with the immunosuppression also. And one more finding, as she was showing in the clinical picture, she had a lot of cutaneous ulcers. So cutaneous ulcerations and dermatomyositis also carries high risk of malignancy. So this particular patient, there is a very good chance that there might be an occult malignancy sitting somewhere and causing all the symptoms. And so far, we have done ultrasound, endoscopy and all that. We have not been able to pick up any malignancy, but eventually it may show up. And probably that is also the reason why she is not showing adequate response to immunosuppression. So any patient of inflammatory myositis, whenever they present with respiratory symptoms, there are three things that we have to look at. Is it the respiratory muscle involvement primarily due to the myositis itself? Okay, they may not have any pulmonary parenchymal involvement, but it is their respiratory muscle weakness which may be causing the respiratory distress. We always have to consider whether there is a coexistent infection which is causing the respiratory symptoms and whether there is an interstitial lung disease, because treatment of all of these will be different. The type of immunosuppression which we would like to start in each of these patients would be different. So say for example, if a person has primary respiratory muscle involvement as the cause for pulmonary symptoms, the first thing that we would do would be give pulse steroids. Okay, so without pulse steroids, we might eventually lose the patient also. It can be that bad. So pulse steroids would be the first choice when somebody has respiratory muscle involvement as such. If there is interstitial lung disease as such, we may not really have to give pulse steroids, but what we would restrict to is 1 mg per kg of steroids along with a second line immunosuppression being started, and we can accordingly adjust the treatment. If there is an infection, first thing to address is infection, and subsequently we will have to see what amount of immunosuppression has to be started. So ILD is a common complication associated with inflammatory myopathies. The prevalence of ILD has been found to be very wide, meaning in few studies it is documented to be about 20% and in few studies documented to be up to 70%. And the risk of interstitial lung disease in patients with myositis is quite high in the Asian population. Increased risk of morbidity and mortality is seen if at all the patient has interstitial lung disease. Definitely needs a multidisciplinary approach. And certain antibodies, as I have already discussed in the myositis profile, they mark a high risk for interstitial lung disease. So if we look at the overall risk factors for ILD in myositis, there are certain clinical risk factors like, as I said, minimal muscle involvement, predominant skin involvement, and some amount of constitutional symptoms. As far as the lab factors are concerned, certain anti-synthetase antibodies and anti-MDA5. Elevated inflammatory markers, as we had seen in this particular patient, also carries high risk for ILD. Older age of disease onset carries high risk for ILD, and male gender also carries high risk for ILD. So once we have evaluated a patient with a detailed history, clinical examination, CT and pulmonary function tests have already been done, and we have made a diagnosis of myositis with interstitial lung disease, what we need to do next is we have to characterize whether the disease is mild to moderate or it is severe or whether it is rapidly progressive, because the amount of immunosuppression will depend on this particular characterization of the disease. Also, we have to note that whether patient has other manifestations like dermatomyositis carries high risk of vasculitis. In this patient also, they were on the nerve conduction study had shown some demyelinating features, right? So when we see demyelinating features on nerve conduction study, again, we have to be careful because it may be showing us that patient is also developing a component of vasculitis. And in that case also, the immunosuppression has to be much more aggressive. So when we look at what kind of immunomodulators we use in patients with dermatomyositis presenting with interstitial lung disease, all patients need to be given steroids, but if the disease is mild, we can start off with 0.5 mg per kg steroids. If the disease is severe, as I mentioned, we start off with pulse steroids. Rapidly progressive disease also, any patient who is requiring hospitalization, is requiring oxygen support or ventilatory support, definitely we have to start off with pulse steroids. That is the only thing which will show immediate benefit. In mild to moderate disease, the second line of immunosuppression after steroids we consider is mycophenolate and azathioprine. In severe diseases, we can consider cyclophosphamide. And of late, we have a lot of studies wherein we have proven benefit of using biologicals in myositis. So in some patients who have not shown adequate response, or if it is rapidly progressive, we can also consider usage of rituximab. So in the initial induction therapy followed by a maintenance therapy with either MMF, azathioprine, or even cyclosporin tacrolimus have also been used. And subsequently, if the disease remains stable, as I mentioned in the previous case also, we would like to continue the same immunosuppression. But if they are progressing, we will again have to hike up the medications. We have to go from MMF to azathioprine. We may have to switch up to cyclophosphamide. If still inadequate response, we may have to switch up to rituximab. In inflammatory myositis with a rapidly progressive disease, there is also a role of IVIG. In a hospitalized patient, if they have significant respiratory involvement and all that, and if they've not shown adequate response to the pulse dose of steroids which we have started initially, then IVIG is also one of the options which may give adequate benefit. So the other medications also have been tried, like JAK inhibitors and abatacept have also been tried, but not in routine use as of now. So again, once patients have achieved remission, so we go into once in 3 to 6 months, we have to keep following up what is their lung status, repeat their pulmonary function tests. If at all pulmonary function tests show any worsening, we may have to repeat the CT scan also. And accordingly, we will have to decide whether the immunosuppression is adequate or whether we have to change the immunosuppression for this particular patient. So, frankly speaking, there are no standard guidelines like how we saw for systemic sclerosis, interstitial lung disease. There have been multiple trials and there are standard guidelines for management. But in dermatomyositis, there is no standard guidelines. And most of it is experience based and it has been extrapolated from the scleroderma studies as such. Antifibrotics in dermatomyositis, the census trial as such, which we were talking about earlier, it had, apart from systemic sclerosis, there were other connective tissue disease patients also who were included in the study, but the numbers were very few. So in that also, it was shown that if at all there are certain fibrotic features, you can start, but there is no clear-cut indication as to when and how long to give antifibrotics in dermatomyositis. With that, I end the discussion for the second case of myositis. If there are any questions, I will be happy to answer.
Rashmi, I just want to share experience with one female patient.
Okay.
She came with only breathlessness.
Okay.
And fever. So the initial impression was whether it is CAP. So we did chest X-ray and it showed bilateral opacities and we admitted in the ICU, but patient was not responding and there was no fever, though she gave history of fever. Then it led us to, whether we are right in the right direction. Then we did CT. CT showed cough features.
Okay.
No other manifestations, only cough and breathlessness. And it turned out to be anti-Jo positive. And the diagnosis is the antisynthetase syndrome. And she responded to pulse steroid therapy and MMF. She used to come for follow-up for almost 2-3 years, and later on we lost follow-up. But there was no involvement of the muscle at all. Only cough. That's it. No skin lesions also. The mechanics and all that thing was there for the patient.
That's what, Mama. If they have other features, at least diagnosis is made earlier and easier. But most often in the clinical, we are discussing about the skin lesions and all, but in clinical scenario, we also end up like that. Like a patient is admitted in our pulmonology department, then they are not able to come to the diagnosis. Then we may be able to pick up few clinical clues, or there may be no clues at all, as you mentioned. And only on myositis profile, we can get some clues, and it tells us that immunosuppression is going to help in those kind of cases. So recently I had one patient, he is a 32-year-old male who had COVID, I think during the first wave. Then subsequently 3 months later, he was on steroids. Once steroids were tapered, every time steroids were brought down below 30 milligrams, he kept worsening. So he was overloaded with steroids. He had developed evident features of Cushing's syndrome and all that. Then he was referred for, he came to our hospital for further evaluation. And then when we looked at the features, again, CT features were mostly looking like post-COVID sequelae only. But since he was not responding very well every time, so most of the other investigations like ANA, ANCA and all was done. He was evaluated in BGS hospital, everything was negative. Only thing which was missed out was myositis profile. So when I did that, his Jo1 turned out to be positive. I started him on mycophenolate, didn't respond very well, stepped up the therapy to cyclophosphamide. Now he is doing better. We have tapered steroids to about 10 mg and still he is holding on well, and we are able to get him out of all the side effects which the steroids are. He has been on more than 30 mg of steroids for almost a year now, because every time it was treated as COVID sequelae, and they kept stepping up those. But after giving him cyclophosphamide, he's improved. So that's where myositis profile has actually helped a lot of patients. But expense of myositis profile is one thing which, we may not be able to do it in all of the patients.
One thing I would add is post-COVID, increasing the autoimmune detection is one big question, like this case. And like the one which you just now said, that are the steroids suppressing the immunity and bringing out the autoimmune condition?
We don't know whether it is actually increasing the overall incidence of autoimmune diseases, or it is just that whatever was, like a sort of subclinical thing which is becoming evident now, probably because of some amount of immune modulation and all that. But yes, we are definitely seeing a lot more cases than the pre-COVID season, and we have seen a lot of myositis patients, as Sir mentioned, interstitial lung disease is also, the manifestations have, the number of patients we are seeing has actually increased, and we have seen quite severe myositis patients who have not responded to any type of immunosuppression. Few of my colleagues who are working in other hospitals like Apollo and Fortis and all, in fact, we discussed about 2 patients of myositis who did not make it. They lost the patients. All of these patients had myositis with ILD without much clinical, dermatological manifestations and all that. So definitely there is a rise, but we do not know the exact explanation why this has happened.
We also had one case following vaccination, COVID vaccination. So he presented only with the heliotrope rash.
Okay.
And had no other symptoms of weakness or anything. But her MDA was positive.
Yes, was positive. So I hate yes.
This
was present by Latin.
And that was, they gave us sort of COVID related findings.
Okay, sir. So this patient, when we had discussed also, there were 2 antibodies which were positive in her myositis profile, which is actually contradictory. The Me2 alpha is supposed to mark a very good prognosis in myositis patients, and MDA5 marks the worst prognosis. So she's got those 2 antibody positivity, but we'll have to give importance to the the anti-MDA5 as such. So if at all she comes for a follow-up, I think and if she's not improving still with MS, then we should either step up her therapy to cyclophosphamide, or we have to go into a much more detailed evaluation to see whether we have missed out any malignancy.
So we are suspecting, that's what, even I also suspecting some kind of malignancy. What should be?
Yes. Yes.
Yes. The autoimmune profile. Here please report comes, we have 1 + 2 + 3 +. What is the report is only 1 +? Do we take it significant and start the treatment or something?
I think the next session we have a discussion about the ANA profile. I think Dr. Thakur will be talking about it. So I'll leave the question to him.
Thank you for the nice presentation. It was really nice. But I want to ask you, how do you go about managing a patient without ILD? Let's say an inflammatory myositis without ILD. Do you start them on steroids or steroid sparing agents initially?
We start both, because steroid sparing agents usually take about 4 to 6 weeks to show the benefit. So the only thing which can give them immediate relief and get them out of the acute phase is steroids. Okay. But if there is no interstitial lung disease, we don't really have to consider these high immunosuppressants. First choice would be methotrexate. Okay. So no lung involvement, methotrexate is the drug of choice. Second choice would be either cyclosporin or tacrolimus. If at all there is a lung involvement, only we will have to consider drugs like mycophenolate, azathioprine, cyclophosphamide and all that. Most of the myositis patients respond very well to methotrexate. Okay, we start them on 0.5 mg per kg steroids with a gradual taper over the next 2 to 3 months. We step up the dose of methotrexate. We start it like a 10 mg per week, increase it to 15 mg. See, many a times it becomes difficult because patients will have elevation of OTPT also. So at that point of time, how much of methotrexate are we going to give? Because methotrexate is not supposed to be given when somebody has transaminitis. So we'll have to start with a low dose, step up the dosages. Once the enzymes are a little better after we have started steroids, we go up to 20 to 25 mg per week. And most of the myositis patients without other organ involvement will respond to methotrexate itself.
What my concern was, because high dose steroids causes itself, it can cause steroid-induced myopathy.
Yes.
Because we see in other ILDs when we give high dose steroid, let's say above 0.5 mg per kg, patient come back to us with proximal muscle weakness. Maybe we suspect that time steroid-induced myopathy because it was started after steroids.
Correct.
How frequently do you encounter such patients who are known case of inflammatory myositis, given steroid without improving, rather they come with worsening? Is that very frequently encountered?
Yes, almost half of the patients will have steroid-induced myopathy, especially if we have given them 1 mg per kg steroids, then definitely we will see that plane of worsening weakness. So there are few ways in which you will be able to make out. So if at all overall clinical condition has improved, but only they are complaining of the proximal weakness, if the muscle enzymes have improved, Okay, then we will think in terms of steroid-induced myopathy and trying to bring down the dosages of steroids at the earliest. And we reassure the patient that once the dosages of steroids are brought down, they're going to improve. Along with that, we will have to give them calcium, vitamin D supplements also to make it little more better. But if at all we see that when they complain of progressive weakness, if the muscle enzymes are also increasing, or if they are showing other manifestations of dermatomyositis, then we know that probably disease itself is worsening and we may have to step up the immunosuppression itself. So this is a very common clinical scenario, and every patient, the decision might be different in this kind of case.
So in that scenario, you would decrease the dose of steroids and what for the symptoms?
We would like to decrease the dose of steroid. So biologics have taken over the treatment in this kind of scenario itself. So most of the patients, we know that, like I was talking about an injection called as rituximab, right? So if a patient has rapidly progressive dermatomyositis and we are ending up giving them pulse steroids and very high dose of steroids, if we administer a biologic, we can rapidly bring down the dose of steroids to, almost like 20 mg or 15 mg immediately after giving the biologic. So that's where off late, we are using biologics also like certain first line agents. It depends on individual patient. We cannot make a generalized decision. We'll have to decide which patient requires that kind of care.
How frequently you want to do a muscle biopsy?
Yeah, see, if at all, muscle biopsy basically to differentiate the steroid myopathy and this, not much, because it is an invasive procedure. So if we are unable to conclude with the clinical decisions and we reduce the dose of steroids, still the weakness is not improving, and we do not have very clear-cut evidence as far as their blood tests are concerned, only then we will do it. My clinical practice, I can say that muscle biopsy, the need for muscle biopsy has come down significantly these days. We were doing it probably about 5 years ago, almost all patients of myositis, we were doing it, but now it is very less.
Thank
Thank you, Dr. Anisha. That was a wonderful presentation. Thank you, madam. So thank you, audience, for your patience. We'll now break for tea for 15 minutes, not more than that. So we join back. Thank you.
One more interesting case is we'll finish. That one that we complete. But decide this, they just asked me to inform. He comes to that. Water.
Welcome back. I hope everyone are refreshed now. Okay. So now let's move on for the next session. So it will be the first expert speaker dialectic lecture by Dr. Karthik Badrayan, who is a consultant rheumatologist from M.S.Ramaiah Hospital. So he'll be talking about the ANA, what, when, and why. Here we.
Yeah. Good morning. Am I audible? So, I'm Dr. Karthik Badrayan.
I'll be giving a short talk on this complex nightmare for others to say, just say ANA is like one, like a black hole, like, you don't know what anything about it. You just order ANA, some report comes, you don't know it's positive, negative, what comes positive in it. And then the only thing we do is just refer to the rheumatologist. So this talk is mainly based for PGs. It's a simple clinical approach and more of practical knowledge rather than the theory stuffs given in that textbooks. Okay, before we start the details, always remember, a positive ANA means the autoantibodies are present. And by itself, ANA does not, a positive ANA does not mean there is any autoimmune disease or there is no need for any therapy. Just a positive report does not say the patient has any disease or does not require any therapy. And all autoimmune diseases can be treated. So never be scared of autoimmune diseases. And never, please, never do an ANA test or any antibody test without background clinical suspicion or having a provisional diagnosis, because you might get unwanted results. So, before we go, what is ANA? As we know, it's anti-nuclear antibodies. Does anyone know anything else in details? So these are antibodies targeted against the nucleus, the contents of the nucleus. So it was first observed in 1948 in the patients of SLE. So initially we thought it could be the LE cells. So they usually saw it in the SLEs. These antigens, the antigens were DNA, RNA, histones, and nucleolate, and centromeres. And antibodies produced against these antigens are called ANA, anti-nuclear antibodies. And how do we detect ANA? So there are many methods. Most important is your indirect immunofluorescence, EIA or ELISA, the Western immunoblot, which is very famous for the ANA profile, the multiplex immunoassay, and the flow cytometry, which is the recent ones. So in coming to these detections, the most common and the most important detection for us in ANA is by IF, immunofluorescence. So here there is fluorescent labeled antibodies which are directed against these antibodies. So when they comes positive, we say it's ANA is positive by IF. So coming to immunofluorescence patterns. So the pattern of immunofluorescence, again, we say how are these patterns dependent, because where are the targets? So one is the important is your substrate. So what is the substrate like? We all know there are many substrates, like on which cells do we do ANA positives. So initially, before they used to do it on rats or monkeys, kidney cells or the liver cells. But now we have evolved and the sensitivity was very less with these animal cells. So now the substrates are the Hep2 antigens. That is your laryngeal carcinoma of the human cells. We take those as a substrate and we do tests on these things. So what are the parameters you have to see in the ANA report? One is the pattern of fluorescence. What pattern is coming, whether it's homogeneous or heterogeneous or speckled. The substrate used. Always make sure that the labs are mentioning what substrate are they using, because the sensitivity depends on it. And the titer. How much is the titer? So these three important things we have to look for in the ANA report. So what are the different patterns? So coming here, there are main 5 patterns which you have to be concentrated about. One is the periphery. Only the periphery of the rim of the nucleus is being taken up by the fluorescence. Or homogeneous. Homogeneous, the whole of the nucleus will be labeled. Speckled. Again, here there will be speckling of the nucleus, the centromere pattern and the nucleolar pattern. And each pattern will be seen in different diseases. So coming to this, you can see this. This is more of a centromere. Where we see inside the nucleus is centromere pattern. This is the nucleolar pattern. This is speckled. And this is the homogeneous pattern. So based on the patterns, we can know approximately what type of disease could be there. So homogeneous, it's almost 60 to 80% always present in SLE. So typical of SLE is always a homogeneous ANA pattern. Whereas speckled, you can see it in different diseases, like your anti-Ro and anti-La. That is your pregnancy-induced or neonatal SLEs, and you can see it in RLPs. That is again characteristic of SLE, or anti-SLC 70, which is a systemic sclerosis. So you can see it in speckled. And centromere, you can see it in more of localized systemic sclerosis. And nuclear or cytomelastoid, these are present in myositis or any other mixed connective tissue disorders. So the substrate, which I was telling you, initially we used to use the animal substrate, which was not specific or sensitive for our diseases. But now we have started using HEP2 cell lines, which is the laryngeal carcinoma cell lines, which is more sensitive for anti-Ro and anti-La antibodies. So the intensities. So coming to the intensities. So this is how the substrate looks in the microscope. So 0, there's no intensity. 1, there's some intensity coming. Based on these, the pathologist gives us the intensity, whether it's 0, +1, +2, +3, +4. So usually 0 or +1 we don't consider as positivity unless there's strong 0 though is like negative. 1 plus more of 1 plus and 2 plus we consider only when there's a strong clinical history. Otherwise, do not just a simple 1 plus coming positive without no clinical history or no clinical symptoms. Do not consider it as a positive report. So, which ANA test to order? Like whenever we suspect a clinical connective tissue disorder, we are always confused. What ANA to, because we saw so many techniques to be mentioned. Like IF, fluid cytometry, ELISA, and even ANA profile. And each one costs a different. It's very expensive cost test. So the important thing we'll have to know always when you suspect a connective tissue disorder, always send first your first and gold standard test as immunofluorescence. So whenever you're suspecting any connective tissue disorder, always send for immunofluorescence test because the sensitivity is more than 95%. And please do not send ANA profile as the first investigation because you might get positivity, like some unknown antibodies come positive and then you start scratching your head, what could it be, what could it be? But your ANA titer itself could be negative. So because ANA profile is not sensitive, please always send for IF. And when do we send ANA profile? So only when there's a clinical suspicion of an autoimmune connective tissue disorder. Please do not send for any random GIA or any rheumatoid arthritis or any osteoarthritis or some bone pain, fatigue. Please do not send them. Only when there's a clinical suspicion of a connective tissue disorder, when there's a mixed picture, only send to them. And if ANA screening is negative, the patient must be reconsidered or re-evaluated. Once just the ANA is negative, please do not jump saying that we'll send some other antibodies. No, reconsider. Always reconsider your diagnosis and think of it. And most of the autoimmune diseases are evolving diseases. It need not be like the first visit he comes, he'll come with a full picture. So he might come with a full picture maybe after 6 months or 1 year. So you might have to send ANA later only when there's again strong. So the diseases where ANA helps us in diagnosis is definitely SLE and systemic sclerosis or scleroderma, where you see more than 95 to 80, 100% all patients coming with ANA positivity. The recent ACR guidance says that without ANA positivity, you cannot label the patient as SLE itself. And diseases where ANA is used as a prognostic marker. So here we use it as JIA because in JIA, juvenile oligoarthritis, ANA positive determines whether the child goes into becoming more of uveitis or more of systemic diseases or not. And then conditions where it's like very not optimal. These are like your drug-induced SLE or MCTD. So here you need to have a ANA positivity. Without ANA positivity, please do not diagnose any MCTD or myositis or drug-induced SLE. So broad spectrum, like when you suspect ANA, if it's negative, always reconsider. Please do not jump into any other antibody titering without ANA positive. So if there's a positive ANA or low titer with high clinical suspicion, only then you go for next step of antibody detection. Based on again the clinical involvement. Based on which clinical involvement is there, go for only that specific antibody involvement. And please do not keep ordering for unnecessary antibodies without any clinical suspicion or ANA, simple ANA by IF positivity. And when not to, if you're suspecting any rheumatoid arthritis, please do not send ANA because it's not going to be positive. The sensitivity is only hardly 10 to 20% or hardly 30%. So please do not confirm your rheumatoid arthritis with ANA per se. Any vague symptoms like fatigue, lower backache, musculoskeletal pain, please do not send ANA because it's not a reliable marker again. And for asymptomatic individuals, please do not send because again you get positivity in many other conditions. And once your ANA is positive, please don't keep repeating. You know, we have a habit like once we get the ANA test positivity, unless you're looking for prognostic factors. Otherwise, it's just a simple say, don't keep repeating ANAs. Like once it was done outside lab, it was positive, but should we repeat it once more? No. Once it's positive, it is always positive if it's fitting in the clinical scenario. And if it's negative, you can only repeat it again if the patient has devolved into another symptom or new symptoms are added, new syndrome is developed. Only then, and clinical suspicion, only then you can repeat. So the presence in healthy individuals. So ANA can be positive in healthy individuals also. As we see, you know, if you take a titer, low titers of 1:10 or 1:40, up to 30% of individuals sitting here also can have ANA positivity. That doesn't mean that the patient or the individual is going to get an autoimmune disease or has something else in here. So normally also up to 30% we can have. But that is why we have these titers. So when we increase the titer, when we increase the dilutions, the positivity reduces. So as a per se, the recent ACR guidelines says initially it was up to 1:160 was the cutoff value for considering ANA positivity. But now we have reduced it to 1:80. So anything less than 1:80, please do not consider it as a positive ANA. So other conditions where ANA can be positive, when we are looking for some other condition and suddenly ANA comes positive, what are the conditions? One is normal, it can be positive, liver diseases like chronic hepatitis, infections like tuberculosis or any parasitic influences, infections or syphilis can come with positive ANA. Skin diseases like psoriasis, malignancies like breast cancer, prostate cancer, they can come with ANA positivity. So always remember in mind, it could be falsely positive also. ANA does not mean only autoimmune always. So the take home messages will be positive ANA does not indicate the presence of autoimmune disease and does not require immediate therapy just because of the ANA positive report. And do not do autoantibodies without any clinical evaluation. So just do not randomly send for any autoantibodies without proper, you have a background of what is the symptoms or any syndrome is fitting in something in a suspicion with a probable diagnosis. And always the gold standard and initial screening test for ANA is always by IF, and please do not send profile first hand itself. Only when your IF is positive, only then send for your profile. And the ANA titer of 1:80 is considered positive. So as we know, it can be positive in the normal population as well as in other conditions, which is not other autoimmune conditions also. And autoimmune diseases can be treated. Thank you.
Thank you, Dr. Karthik. Crisp and clear. Now we will not make mistakes. We will not send ANA profiles. First, we have to send ANA-IF that is relevant. We'll move on to next session. Case number 3.
I invite Dr. Divya, Senior Resident at the Department of Respiratory Medicine for the third and last case discussion. Dr. Kavish Gupta and Dr. Sarshini, please to moderate the session, lead the discussion.
Audible? I'm Dr. Divya Spendan, Now, I'll be discussing yet another CTD ILD case which we came across in our clinical practice. My patient was a 40-year-old gentleman who was a non-smoker, farmer, with a background history of systemic hypertension of 3 months duration on telmisartan 40 mg. He presented to us in April this year with the chief complaints of cough, breathlessness on exertion, and polyarthralgia of 3 months duration. Cough was insidious in onset, progressive, non-productive, with no postural or diurnal variation. Breathlessness was also insidious in onset, progressive. Initially, it was of grade 1 to 2 MMRC, and it progressed to grade 3 to 4 MMRC over 20 days. There was no diurnal or postural variation for breathlessness as well. Patient denied any history of fever, chest pain, wheeze or hemoptysis, nor there was any history of PND or orthopnea, palpitations or syncope. Patient also presented with polyarthralgia involving bilateral knees, elbows, all joints of hand. Pain was present throughout the day. There was no early morning joint stiffness, swollen joints, no myalgia, pain, abdomen or diarrhea. On examination, patient was conscious and oriented, and vitals showed a saturation of 88% on Ramaiah, and patient had mild tachycardia and tachypnea as well, but blood pressure and temperature were within normal limits. Respiratory system examination showed bilateral normal vesicular blood sounds with mid-inspiratory fine crepitations over bilateral interscapular and infrascapular areas. So 2 months prior to our admission, patient was hospitalized in a private hospital in Davagere. There he was evaluated, and upon evaluation it was found that rheumatoid factor was positive, though ANA profile was negative, and HRCT thorax was done, that will be discussed later on by Dr. Connective. And patient was treated with IV antibiotics, IV and oral steroids, oxygen, and other supportive measures. And patient was better and he got discharged, but 1 month later he was again admitted in a private hospital that was in Udupi. It was in view of recurrence of symptoms. There also he was treated in a similar manner with IV antibiotics, steroids, oxygen, and other supportive measures. So in total, he got 32 days of steroids in both the hospitals. So in our hospital, when we evaluated, it was found that total leukocyte count and ESR were high, and other routine investigations involved, including these viral markers and 2D echo, were within normal limits. Apart from this routine investigations, we had also sent ANAIF, CNGA, PNGA, anti-GBM, and ANA profile. Meanwhile, we started the patient on empirical treatment with IV antibiotics, nebulizations, oxygen, and other supportive measures. We obtained an orthopedic consultation in view of polyarthralgia, and they advised to start the patient on methotrexate, Polvite, deflazacort, and NSAIDs. Lung function assessment showed severe restrictive pattern in spirometry. The patient was not able to perform DSO because of cough. And now the results of ANA profile was available, and that showed strong positivity of anti-Rho52 antibodies. Now I invite Dr. Tanil sir to give his valuable insights regarding HRCT images of the patient.
So when we start reading the CT chest for any case which has come in terms of query, ILD, what type of ILD is it? We do ask the clinicians, do you have a probable clinical diagnosis? Because that will cut short our lot of questions. So what's your probable clinical diagnosis?
Clinically, actually, patient did not have any symptoms of scleroderma or rheumatoid arthritis or any connective tissue disease. So, in view of polyarthralgia and for breathlessness, Outside hospital, he was evaluated with the rheumatoid factor and ANA profile. Rheumatoid factor was positive in outside hospital, so we went ahead with the ANA profile.
RO52 positive, strongly positive.
Was positive.
So this patient had multiple patterns on CT chest. Here we see there are small areas of ground glass opacities which are very bronchial. Mild tubular dilatation of bronchi, but this is not bronchiectasis, this is just bronchial ectasia with surrounding ground glass opacities. Interstitial thickening, which is both peribronchial and subpleural in location. There are some nodules present here, which are both soft tissue density nodules and ground glass nodules. Small area of alveolar opacity, similar opacities on the left side. Here you can see better. This is the area of ground glass opacity, which is peribronchial. Subpleural area of ground glass opacity, interstitial thickening, and some mild pleural thickening here. Here, what we see here, there are centrilobular nodules, which are ground glass, and surrounding there is a ground glass opacity. Mild tubular bronchiectasis or bronchial dilatation. On the left lung, ground glass opacities, subpleural and central interstitial thickening, nodules present in the lung, some type of alveolar opacities behaving like an organizing pneumonia with nodules. As we come to the lung basis, ground glass opacities, central and peripheral interstitial thickening, mild tubular dilatation of bronchi, and ground glass consolidations in lateral lower lobes. Similar things, zoomed up images. These are areas of ground glass consolidations in lateral lower lobes. So what is not present here is there is no air traffic, there is no mosaic attenuation, there are no peribronchial nodules, most are centrilobular nodules. So these are the few features which we need to keep in mind. And there are 2-3 patterns. One is an organizing pneumonia pattern, which is developing as consolidation, and the second is a bronchiolitis. So when we have ground glass nodules, which are centrilobular in nature and surrounding ground glass opacity with interstitial thickening. There were few enlarged nodes in the pretracheal region, which are non-necrotic, non-calcified. So this type of patterns are there. We need to go into depth that when there is a lymphocyte-related lung injury, it can either affect the lung or the mediastinum. In the lung, there can be 3 involvements: airway abnormalities, interstitial pneumonias, and liquid olfactory disorders. Airway abnormalities mostly present as bronchiectasis and bronchiolitis. Follicular bronchiolitis given to ground glass nodules, which are centrilobular in nature. We should not get it confused with perilymphatic nodules, which are more present in cases of sarcoidosis. RA and Sjogren syndrome can both present as centrilobular nodules. If the pattern is more of towards interstitial pattern, it can present as either NSIP pattern, a UIP pattern, or organizing pneumonia pattern. All 3 patterns are possible in this type of lung injury. Sometimes they can be cysts, and you can have an LIP pattern also. If it's involving the lymphoproliferative tissue, then the patient can even present as mild lymphoma and amyloidosis. Mediastinal involvement, most common will be lymph node enlargement, thymic lymphoid hypoplasia, multiple thymocytes, and mouth lymphoma. So in this patient, what we had is we had bronchiectasis, we had follicular bronchiolitis, we had an NSIP pattern, an OP pattern, and some enlarged lymph nodes. So these are few images from the literature which shows different types of acetylrated ILD, most commonly like Sjogren's syndrome, where there is tubular dilation of bronchi. There is subpleural and central interstitial thickening with ground-glass nodules, which are centrally located nodules. Interstitial thickening in the subpleural regions, cysts, some traction and addition of bronchi. This is a UIP pattern, the same thing where we have honeycombing in the subpleural region in the left lower row. Ground-glass opacity with interstitial thickening, typical of Marek lymphoma. And organizing pneumonia, this is a classical feature of an organizing pneumonia, in which there is a central hypodensity and peripheral ground-glass opacity.
Thank you, sir, for enlightening us on the topic. So, after an MDT discussion, we came to a diagnosis of Sjogren's syndrome associated ILD with the background of systemic hypertension. So, as per rheumatologist advice, we started the patient on HCQ 200 mg PD, the bisonon, along with calcium and vitamin D supplements. So, on follow-up, now patient's symptoms are improving, breathlessness decreased, patient has a better quality of sleep. However, patient needs further follow-up and assessment of treatment response. Now I call upon Dr. Harshini ma'am for further discussion.
All right, so this patient, basically the issues we had were polyarthralgia, but there was no significant arthritis as such, no evident arthritis, no deformities. Patient had an ILD, most like, as I've mentioned, it was a mixed pattern, but we did see a lot of NSIP features also. A rheumatoid factor positivity, which is not very well defined because we do not know what is the method they have used. If they have used only the slide method and given it as just positive and negative, it may not be reliable. So what we follow at present is immunoturbidometry, by which they actually have to give the titer of rheumatoid factor, and then we see whether it is significantly positive or not. And row 52, I think AA profile has been repeated twice, and in both of them it has shown significant positivity. So with these possibilities, we can conclude that patient has had we can give a diagnosis of Sjogren's syndrome, but again, we'll have to delineate whether it is a primary Sjogren's syndrome or Sjogren secondary to other causes. So can anybody tell me if at all you are aware of any differences between primary and secondary Sjogren? Medicine guys?
Primary only lungs is only the glandular involvement is there.
Glandular involvement.
Secondary along with lungs.
Okay.
Lungs, involvement of the lungs and the hospitals.
Okay. Okay, all right. So if we have to look, see, basically primary Sjogren is there is no other disease which is causing symptoms of Sjogren's syndrome. Secondary Sjogren is as a part of either a patient has been suffering with rheumatoid arthritis or any other connective tissue disease like scleroderma and all that, and subsequently they start manifesting with symptoms of Sjogren's syndrome, then we call it a secondary Sjogren. So if we have to, so clinical clues as such in this particular case, if we, any patient who presents like this, we will have to, since he had polyarthralgia, we will have to look whether they have any typical deformities like what rheumatoid patients would have. If not obvious deformities, at least limitation of the wrist joint or any evident synovitis of the joints would also give us a clue that patient has got an arthritis which is probably going in favor of rheumatoid arthritis. Then apart from the joint involvement, we also have to look for certain other features, like in the skin we can see the rheumatoid nodules. If at all a patient has an active connective tissue disease, you can see something called as rheumatoid nodules, which is more commonly seen on the extensor aspects. And for the Sjogren's syndrome as such, they may have keratoconjunctivitis, because of which they can have irritation in the eyes. On clinical examination, we may be able to pick up clinical signs of conjunctivitis. We may be able to pick up the clinical signs of enlargement of glands, enlargement of lacrimal glands, enlargement of parotid glands. Most often it is missed unless and until we suspect it. So glandular enlargement can also be picked up if at all the patient is examined very keenly. And we'll also have to ask them for symptoms of dryness of the mouth, dryness of eyes. Most of the patients do not come up with these symptoms. Like say example, dryness of eyes, most often they are not even aware. Like when we suspect clinically in this patient also probably we should get an off-style evaluation done whether the patient really has reduced tear secretion. That will give us one more clue towards possibility of Sjogren's syndrome. So if we look at differences between primary and secondary Sjogren, primary Sjogren syndrome is predominantly a female disease. So the ratio of male to female is almost 9:1, 9:1 to 14:1. So it's predominantly seen in women. Male patients with primary Sjogren is very rare. Whereas secondary to rheumatoid arthritis, the ratio is about 3:1. So it is also common to be seen in males. Primary Sjogren, most often it is a low-grade inflammatory arthritis. We may not be able to pick up any evident synovitis, joint limitation. It is a non-deforming arthritis in primary Sjogren. Whereas in rheumatoid arthritis, it is an aggressive inflammatory arthritis with evident synovitis, joint deformities, which can be picked up on clinical examination. Rheumatoid factor can be positive in both of them. That is why rheumatoid factor carries a low specificity. Rheumatoid factor is positive in multiple other diseases apart from rheumatoid arthritis. Even patients with hepatitis B and C positivity can also have rheumatoid factor positivity. So just rheumatoid factor positivity does not actually give us any particular clues. So how can we make our diagnosis better? Anti-CCP probably in this patient would have made a difference. If at all anti-CCP was positive, then it would have told us that it is secondary to rheumatoid arthritis. Anti-CCP positivity is not seen in any other connective tissue disease. It is very specific to rheumatoid arthritis as such. 99% specificity for rheumatoid arthritis is seen with anti-CCP. Primary Sjogren presenting with ILD is also not so common. So we see a lot of glandular manifestations. We see a lot of constitutional symptoms. Patients presenting with low-grade fever, weight loss, loss of appetite, and lymphadenopathy. These kind of manifestations are more common, whereas interstitial lung disease is more commonly seen in patients who have had long-standing rheumatoid arthritis. The predominant pattern of ILD also differs. We know that in rheumatoid mostly we see the UIP pattern, whereas in Sjogren it is predominantly NSIP pattern. And primary Sjogren, even if they have to present with an interstitial lung disease, it is mostly late in the course of disease, meaning they would have had glandular manifestations for a long time and then manifest with the lung disease. Whereas in rheumatoids, we see a lot of patients who present initially with ILD. We evaluate them and only then we see that either rheumatoid factor, anti-CCP positivity and all have come up. So initially also it can present with the lung disease itself. Overall, in both Sjogren as well as rheumatoid arthritis, but meaning to say primary Sjogren or secondary Sjogren, there are certain risk factors for interstitial lung disease as such. So males carry high risk for interstitial lung disease. Smoking is one of the most important risk factors. It contributes a lot to development of ILD. Long duration of disease. So in rheumatoid especially, we say if a patient has had disease at least for about 10 years, then the risk of ILD increases. Inadequate treatment. Somebody who's been initiated on DMARDs right from the beginning, the risk of development of ILD at a later stage is very less. Late onset rheumatoid arthritis or elderly onset rheumatoid arthritis, we call it as LORA, the age of onset being beyond 60 years. In these patients also, the risk of interstitial lung disease is quite high. High titer of antibodies, it can be either rheumatoid factor, anti-CCP, the ones which we have discussed now, the Rho52 and all. Any of these high titer of antibodies carry high risk for ILD. And other extra articular manifestations also, like even, for example, lymphadenopathy or vasculitis and all, they mark high risk for interstitial involvement in patients with Sjogren's syndrome. So there will be usually two types of clinical presentation. We have been discussing so far that somebody already has features of connective tissue disease and then comes with new onset of respiratory symptoms. It becomes slightly easier to diagnose those patients. The challenge is when they present with isolated respiratory symptoms and only on further evaluation, clinically, if we are not able to make out and only on antibody profile, we are able to make out whether they have rheumatoid arthritis or Sjogren's syndrome. So this will be the more challenging kind of patients that we handle on a day-to-day basis. So if somebody is already diagnosed with a primary or a secondary Sjogren, is there a role for regular screening of these patients for interstitial lung disease? No, we don't have to screen them unless and until they are symptomatic. So asymptomatic patients, there is no role for screening at all. If at all somebody starts developing either exertional breathlessness or cough, which has been present for a long duration, then probably pulmonary function test gives a better clue than chest X-ray. It carries a better sensitivity. TLCO reduced to less than 70% of predicted should definitely suggest that we should go ahead with a CT scan and image their lungs. And ILD, usually the radiological changes correlate well with the corresponding histopathological findings. So lung biopsy is not something which we do on a routine basis, but in this particular patient, if at all we are, sir was discussing about the LIP pattern, the lymphocyte predominant pattern, especially with Sjogren's syndrome, which is a predominant lymphocyte based disease. There are certain other factors also to look at. If they have hypocomplementemia, if there is hypergammaglobulinemia, then we will have to probably think in terms of doing a lung biopsy also, because there might be a different pattern. It can slowly evolve into some kind of lymphoma also. So we will have to be much more careful in those kind of scenarios. So when we talk about patterns of ILD in primary and secondary Sjogren's, as I told, primary Sjogren, mostly we see the NSIP pattern, whereas UIP pattern is seen more commonly in patients with Sjogren's secondary to rheumatoid arthritis. And the patterns as such, UIP pattern, the response to immunosuppression is not very great as compared to the NSIP pattern. So UIP pattern, even after immunosuppression, 5-year survival comes down to about 50% only, but NSIP pattern, they do very well with immunosuppression. There are no clear guidelines as to how to proceed with treatment in a patient with rheumatoid ILD or a patient with Sjogren's syndrome ILD. Definitely steroids are beneficial, and the choice of DMARDs depends on multiple factors. So we look at severity of lung disease. If it is a severe interstitial lung involvement, then mycophenolate or cyclophosphamide should be the choice. We also have to see, like for this patient who had only pulmonary symptoms, probably mycophenolate would be the best choice. But if at all the patient has coexistent articular symptoms, evident arthritis, so mycophenolate does not help much in controlling the joint symptoms. So in those kind of scenario, probably azathioprine should be the drug of choice. So it helps in controlling arthritis as well as helps in controlling the lung disease. Presence of other extraarticular features like vasculitis, then probably cyclophosphamide should be the drug of choice. We have to be careful when we are treating patients with rheumatoid ILD, because certain medications which are very useful in treating rheumatoid arthritis are known to cause pulmonary toxicity also. So we see interstitial pneumonias when we start certain patients on methotrexate, and it is also reported with many other drugs, even sulfasalazine, leflunomide. Many a times we do see that interstitial involvement can happen, but it is rare. So common drugs which have been implicated in pulmonary toxicity which are used in rheumatoid arthritis are methotrexate and the biologic group of medicines, that is TNFIs, both of them. So if a patient has lung involvement, we would prefer to avoid these two medications and try to manage them with the other immunosuppressants. So it is not that, I mean, any patient who started on methotrexate can develop a pulmonary nodulosis. So usually the dosages which we use in treatment of connective tissue disease is less than 25 mg per week. At this dose, the lung involvement, acute interstitial involvement with methotrexate is very less. It is more seen in patients who are given higher dose of methotrexate as a part of chemotherapy. So what we use in CKDs is much less, and the risk of interstitial involvement is less with that. This is an overall algorithm which gives a broad overview of how we can manage patients who present with Sjogren's syndrome and interstitial lung disease. So as with other patients, we assess their the clinical features, the functional capacity in the form of pulmonary function test, HRCP and all. So if the disease is moderate, then we can consider MMF or azathioprine as the first line steroid sparing agents. If it is either a refractory disease which has not responded well to these first line medications, or if there is rapid progression, then we can consider cyclophosphamide, rituximab, and in extreme cases, lung transplant would also be a choice. In a patient who shows adequate response to the initial immunosuppression, as I have mentioned earlier also, we prefer to keep them on a 3 to 6 months follow-up. If they are doing well, we can continue the same immunosuppressants. At any point of time, if we see the disease is worsening, then we would definitely consider switching over to a different immunosuppressant, or whether we have to give biologics would be the concern at that point of time. So this is just a summary slide I have put up at the end of all the 3 cases that we have discussed so far, wherein we are just highlighting on different patterns of ILD, and it is just summarized in the table that which pattern of ILD is seen more commonly in which type of connective tissue disease. So when it comes to scleroderma, we see more of NSIP. Dermatomyositis, we see all patterns equally, NSIP, organizing pneumonia, UIP pattern, AIP pattern is also quite common in dermatomyositis. Primary Sjogren, lymphocytic predominant, that is LIP pattern is also quite common. Rheumatoid arthritis, as I already mentioned, UIP pattern is quite common. In SLE, we do not see much of UIP. It can either be NSIP, and most often in SLE, we see this acute interstitial pneumonia presentation. So acute respiratory distress presenting, interstitial lung disease presenting in an acute manner. More commonly, we see in SLE as well as dermatomyositis. Mixed connective tissue disease, again, NSIP pattern is predominant. We also, apart from interstitial lung disease, we also see multiple other pulmonary manifestations in most of these connective tissue diseases. Like rheumatoid arthritis patients tend to have airway disease like bronchiolitis, and even simple thing like a cricoarytenoid arthritis can cause a laryngeal involvement, and also a lot of other manifestations can also be seen. We do see diffuse alveolar hemorrhage predominantly in patients with SLE as well as ANCA vasculitis. So a broad spectrum of manifestations that we see in pulmonary manifestations that we see in connective tissue diseases, and timely recognition is most important because immunosuppression is really going to help in these cases. Any questions on discussion of this particular case?
Thank you, Dr. Harshini. You elaborated very nicely. The anti-CCP was positive.
Positive, huh?
Yeah.
Yeah. So I was just telling her that it is most likely a rheumatoid-related Sjogren syndrome.
The anti-CCP was not there.
It was done outside. It was positive.
Did this patient had Zika symptom?
There were no Zika
symptoms.
symptoms.
A Sherman's test or a
Yeah, it was done.
biopsy was done.
Skin biopsy, there were no skin lesions. Mainly patient came with polyarthritis. He was not able to walk. And our initial question was whether it is methotrexate induced, like how you said.
Okay.
So because he was on and off on methotrexate, he had visited several hospitals. Whether I am handling the methotrexate induced pneumonitis or it is ILD, and when ANA profile came, it came as a surprise. Didn't expect that at all, that something will be positive. Initial impression was only rheumatoid arthritis, methotrexate induced interstitial lung disease. So you agree that Rho52 is, we can take that seriously in this case. Because no other symptoms of Sjogren.
Yes, ma'am. So this is a part of rheumatoid disease and a secondary Sjogren. We can label it as it is. I was just telling her when I was discussing the case with her that this looks like a rheumatoid related because male gender presenting with predominant lung involvement and only joint disease without any Zika symptoms, no glandular enlargement, and rheumatoid factor was that we do not know what method it was done. And I in fact asked her to please go back and look at anti-CCP. She said she could not find the report.
Yeah, because it was done
outside. Okay. We can label it as rheumatoid with secondary Sjogren and associated interstitial lung disease. So that's why the choice of methotrexate in this patient was actually not correct, because it always gives a lot of confusion whether things have started after, things have worsened after giving methotrexate. Is it methotrexate induced acute interstitial pneumonia, or the patient had a pre-existing interstitial lung disease and it is just worsening over a period of time? Becomes very difficult to differentiate. The only way we could do would be to stop methotrexate, and again we'll have to wait for some period of time. So at this point, we can only think that we should stop methotrexate at any point of time, and we should switch over to a better immunosuppressant, probably mycophenolate. In this patient, probably mycophenolate also would not be a right choice because you did tell me that his articular disease is also severe. So azathioprine would probably be a better choice because it will help in controlling his arthritis as well as joint symptoms. Initial phase steroids. If he's still persistently having symptoms, then we can consider the option of rituximab. Because rituximab also helps very well in lung disease as well as the joint disease control.
I would like to add, this methotrexate will induce acute usually presents an AIP pattern. So we'll have a lot of ground glassing and interstitial thickening rather than these modules which are and bronchiectasis. So that will help us in differentiating methotrexate produced and seizure diet.
Next time, if she come, we can do lip biopsy at least.
No, the patient is from Davangere. So he preferred to go back, and we gave the contact number of a pulmonologist there and the contact. Only for diagnosis he came to us. Okay.
So if they do not have evident Zika symptoms, then an ophthalmology evaluation to do the Shermer's test and your film breakup time and all that. And definitely salivary gland biopsy, as sir suggested, that also will give us whether there are lymphocytic infiltrates in the salivary gland biopsy. That will make our diagnosis a little more stronger. But anyways, this patient will have to be on immunosuppression, and as we have discussed.
He referred him to a rheumatologist, and he said after consulting a rheumatologist, he'll go back to Davangere. I think he was put on MMF.
And most likely they would have started on one of those drugs.
Without having a lip biopsy and a Zika symptom, just based on only poorly arthralgia, can we make a diagnosis of those ones? We can't make
Just
it.
based on
So
polyarthralgia.
I'll tell you the pulmonologist perspective. There is an entity called as interstitial pneumonia with autoimmune features, where we classify patients those who doesn't fulfill exactly into a particular CTD ILD, but they have overlapping features like a CTD symptom and respiratory involvement, like any one of the factors, and with one of the immunological antibodies which is positive. So if two of these domains are there, then we would classify them into an interstitial. We call it as IPAC, interstitial pneumonia with autoimmune features. Might be knowing. Basically, treatment would be remaining the same, but the prognosis will differ. So maybe we could have had a lip biopsy and a Shermer's test to make it more conclusive.
Yes, yes.
Thank you.
So probably the rheumatologist who has seen this patient would have, I have not seen this patient. So whoever has seen might have suggested, I'm not sure, but that would be the ideal way to go ahead. Since Rho52 was positive, we should have definitely gone ahead and done a salivary gland biopsy and also seen whether there is anything else, like, if there was a parotid swelling, we could have probably done it. So we do ultrasound of the glands. Even that has a lot of features to pick up, which, suggests inflammatory infiltrates in the gland and all that. So parotid gland ultrasound can be one of the choices, and CT of the, I think sir would be knowing about that. CT of the salivary glands also.
So mostly the ultrasounds show large edematous glands with a lot of increased vascularity. So that helps us in that. IPAC was a very common these days now, without joint involvements and clinical features, only lung involvement. If radiologist and clinician both are thinking of terms of connective tissue disorder without joint involvement, IPAC is one of the top definitions.
So yes, this patient will probably require a little more detailed evaluation to come to a proper diagnosis as such, but treatment aspect, what has been initiated is right.
Ma'am, we have one patient currently admitted in the ward. Actually, postmenopausal lady came with vague symptoms of fatigue. On evaluation, sinusitis was there, and also the lupus nephritis, proteinuria was there.
There was actually place this 67-year-old lady. Just extensively evaluated for anemia, bone marrow, endoscopies, colonoscopies, everything. One routine evaluation for nothing an ultrasound had mild ascites, mild pleural effusion, and mild to moderate pericardial effusion. So it was referred to us in view of tuberculosis too, for an infectious disease, to rule out any infectious disease pathology because of pericardial effusion, anemia in an elderly lady. She had contact of tuberculosis in the past. Her mother was a few years ago. So keeping in that sense, she was referred to us and we continued her management. Routine urine analysis had both bacteriuria, but it was asymptomatic. There was hematuria too, but proteinuria. But the proteinuria and the hematuria was disproportionate to the amount of WBCs and the bacteriuria. So we proceeded with the urine protein creatinine ratio good positivity. So from there, we then got into an ANA immunofluorescence, homogeneous pattern, good positivity profile. PSDNA was positive, but a good titers of RO. I've sent you the title values. Okay. So now, am I dealing with a lupus nephritis with or is it secondary tolerance? We've started evaluating for this of that evaluations and biopsies. This is
So see, in this case, what will happen is, if there are two coexistent diseases that we are thinking of, the one which is more aggressive is what we have to look at. So if at all there is already proteinuria, the best way to go ahead should be to do a kidney biopsy. And biopsy, if at all it shows evident features of lupus nephritis, with whatever Rho52 positivity or glandular enlargement, anything, the first diagnosis will still be lupus, and it has to be treated aggressively because lupus is the most aggressive connective tissue disease that we handle. So treatment wise, it would not make much of a difference. Again, that would become probably a secondary Sjogren, secondary to lupus. Okay. So when we have to, like we were discussing about how we make a diagnosis without opthal examination and gland biopsy. So all of those become important when we are dealing with primary Sjogren syndrome, when there are no other features, no other connective tissue disease, and we only are evaluating in terms of Sjogren, but there is an evident connective tissue disease like lupus or rheumatoid arthritis, and just the antibody positivity of Rho52 or any of those, we label it as secondary Sjogren. The treatment has to be based on whichever is the most aggressive. So lupus, definitely, if it is lupus nephritis, we have to start with the high dose steroids, and probably that kind of an aggressive disease with severe anemia and all that, cyclophosphamide should be probably the first choice.
So I think I've seen on these. So sir had mentioned about MMF, but then now there's a quick clash between my nephrologist and my hematologist. Whether plus or minus MMF. So we just once close steroids.
What is the biopsy shown? Which class of nephritis? Not done.
Biopsy is not done. There's a lot of issues.
Probably biopsy should tell us what, because everything else will respond to both mycophenolate also, cyclophosphamide also. But if the patient has got features of class 4, which is the most active form of lupus nephritis, if at all we see any crescents, or if we see features of the vascular involvement on that, then we should probably consider cyclo. Or if at all it is quiescent, if it is only class 3 lupus nephritis or something, MMF or even azathioprine also should be a choice. But with such low hemoglobin and all that, you told me that she has got significant anemia, so azathioprine would not be the first choice. So as Dr. Connective mentioned, MMF should be considered at that point. We should see her age also. She's 67 already, right? Yeah. So looking at the side effect profile also, probably MMF should be the first choice. I mean, it is the safest of all the other immunosuppressants that we use. Cyclophosphamide also can cause some amount of renal dysfunction in that age. But renal biopsy is a must.
How often do we see a postmenopausal lady getting SLE?
Less. Yeah, most commonly we see in the age group of 30 to 50. We do have juvenile lupus patients also. I think Dr. Karthik will be dealing with a lot of pediatric patients who present with lupus and all. Above 60 years is very less. Maybe about 10, I can say 5 to 10% only, not more than that.
Probably an overlap also.
Yes, sir. There will be an overlap connective tissue disease kind of features.
Protocol, especially for a lady who's fantastic. But most of the cases there cases of.
So you want to know about the protocol?
Is there a possibility of miscalling, misdiagnosing without proper protocol?
Definitely yes. So your biggest enemy for you, radiologist is your respiratory motion artifact. Okay. So where you say a lot of ground glassing is there, a lot of interstitial thing is there, but once you repeat it, it becomes. So protocoling is very important. Ideal protocol is at least 2 phases. Okay. One can be inspiratory, second can be expiratory. Supine or prone, that is totally the choice based on the first scan. So once you do a first scan, the total inspiratory, and you are seeing a lot of subpleural dependent atelectasis exchanges, do it at prone position, that will go. Second thing is that in patients who are breathless, start the scan from caudocranial. So when you start caudocranial, the patient, if holds the breath for hardly 2-3 seconds also, at least your lung bases will be covered, in which most of the cases will have ILD at the lung basis, especially those cases where you have either UIP or fibrotic NSIP, all those things. So protocoling is very important. So based on your first CT, you can decide your second protocol. Because in cases of HP, where you have air trapping, you need an expiratory phase film. In cases which have dependent electrolysis and dependent lung changes, you need a protocol. And these patterns can be present in different ILDs. It also depends upon what stage of the patient is coming to. a patient who's got completely burnt out disease might be 2 years, 3 years back, he would have got a lot of cellular changes, a lot of interstitial thickening. But at the end of the disease, when it's a fibrotic lung, end-stage lung disease, it will be all UIT pattern that if patient is not treated properly on time. So at what stage? The earlier you detect, you will get more NSIP patterns, more nodules, more organizing pneumonias. But in later stage, you will get fibrotic NSIPs or UIT patterns.
My question is to Dr. Karthik. I wanted one clarification, sir. When doing ANA by IF method, do we get the titer values? If I'm not wrong, we get it as 1 plus 2 plus 3 plus. And what is the role of ELISA in how about the sensitivity of ELISA in doing
Depends on the lab. It usually depends on the lab we're doing. It usually we get a titer, but sometimes we do get 1 plus 2 plus also. So in ELISA, it's again less sensitive result compared to IF. So IF is the gold standard because the sensitivity is more than 95%. So always stick to only IF. In case it is only then we go for the confirmation.
Okay. 1 plus 2 plus, you feel 2 plus is a cutoff of 1 is to 9.
Yeah.
How about ANCA? When we are asking for ANCA, do you suggest to go by ELISA or by IF?
We can go by IF also again.
Which is better, which is like ANA, which has higher sensitivity. If you have to go by one way, both by IF. Thank you.
Sensitivity for ANCA is IF. Specificity is ELISA. So if somebody turns out to be negative on IF, like what we used to do earlier, C ANCA, P ANCA, even if those are negative, but clinically there is a very strong suspicion of ANCA vasculitis in that patient, we go ahead with MPO and PR3. Many a times we see that C ANCA, P ANCA is negative, but MPO and PR3 specifically turn out to be positive. So when it is screening, it is IF. For confirmatory, it is ELISA. There are no more questions. I've just put up a summary slide for CTD. Can you go to the next? So I would like to conclude with this slide. IED carries worse prognosis in connective tissue diseases. So like in lupus, if there is a renal involvement, we call it as worse prognosis. And most of the other ILDs like systemic sclerosis, mixed connective tissue disease, Sjogren's syndrome, rheumatoid, ILD carries a poor prognosis. So early recognition of interstitial disease and timely treatment is what is really important. And this requires a multidisciplinary approach. So in my hospital, I make it compulsory that whenever a patient comes for a 3-monthly visit, they see me and see my pulmonologist both. And if at all we are the patient is declining, then and we are repeating the CT and all, we go sit at like how sir talked about their multidisciplinary team. We also sit with the radiologists together, look at the findings, if there is any progression, what has happened clinically and all, make a combined decision. So my pulmonologist, Dr. Rohan, helps me with what nebulizations, when, how much of oxygen is required. All of those things are taken care by him. So we make sure that patient sees the pulmonologist and the rheumatologist in the same sitting, so that there may be many symptomatic medications that will be which can be better advised by you than us. And as far as immunosuppression is concerned, we will be able to take care of it. Also, vaccinations. We have to stress on the role of vaccinations in patients with interstitial lung disease. So in elderly or with comorbidities, we have certain cutoffs as to when we have to give the pneumococcal vaccine and flu vaccination and all that. Any patient who is diagnosed with interstitial lung disease, the moment dosages of steroids are brought down to somewhere less than 10 milligrams, we would suggest to go ahead with pneumococcal and flu vaccination. We give them a vaccination card and they have to maintain it, take the regular flu vaccination once in a year, because infections are not, they do not just, make the patient hospitalized, they worsen the overall disease itself. The ILD itself can progress. It starts off as an infection and ILD itself can progress. So preventing that severe infection is very important. So role of vaccination is a must. And monitoring, as I already mentioned, PFT is what we use to monitor once in every 3 to 6 months. If there is evidence of clinical or worsening on the PFT, then we will go ahead with HRCT, because I don't want the patient to be exposed to the CT radiation very frequently. So most often in rheumatology practice, if a patient remains stable for, we can repeat the CT after 1 year, or if completely stable, even up to 2 years, we will wait. And we will keep them on good amount of immunosuppression, which means to say, according to the body weight, full dose of immunosuppression for at least 2 years.
Subsequently, if they have remained stable, we start tapering it. Like for say somebody is on 100 mg of azathioprine, we don't stop it immediately. We always taper, bring it down to 75, watch for next 3 to 6 months, bring it down to 50, watch for another 3 to 6 months. And again, there is a debate between whether to stop immunosuppression in ILD or not. So this has been a huge debate topic all across the world, even in our European Congress and all, a lot of discussions. So it is an individual decision. Few immunologists choose to stop the immunosuppression if the patient has remained stable for a period of about 2 to 3 years. But what I have been taught in the institute, where I have learned with the experience of my HOD who's been in the field for more than 30 years, he says bring it down to minimum, but never stop immunosuppression, because the risk of worsening of the disease is much more. And when they come back, they may not respond the same way they have responded in the initial phase. So there are quite a few patients who have been on immunosuppression for maybe 6 years, 7 years, 8 years, and continuing on a minimum dose of immunosuppression for a long period of time. So these are a few summary points I wanted to put up before winding up the session. I thank the pulmonology department, Gayatri ma'am and Pragati ma'am again for giving this opportunity. And I end my talk with this slide. This is our Rheumatology Association, which is very active. The Karnataka Rheumatology Association is the most active among all the other associations in the country in 2 different ways. One, in spreading public awareness. We are doing a lot of public activities in the form of camps. We are visiting medical colleges. We are going to peripheral health centers, trying to screen patients with connective tissue disease, because awareness about these diseases is very less. Most of the patients don't come to us. And the second way is that we are doing a lot of collaborative studies, because there are not much data about Indian patients, how they present and how they respond to immunosuppression. So ours is the only association wherein we are pulling in patients from all the different centers in Karnataka, and we are trying to generate a lot of papers, at least per year. I can say 2 international publications and 2 national publications are coming from our association. So I'm proud to say that I'm a part of this, and I represent it here also. Thank you very much.
Thank you, Dr. Divya, for that presentation, and thank you, moderators, for that enlightening discussion. Now I call upon the next expert expert lecture on trial and biopsy in intestinal analysis by Dr. Bharat Chabria, the assistant professor in the Department of Pulmonary and Critical Care Medicine. Dr. Bharat, over to you.
Thank you, everyone. Thank you, especially Dr. Pragati, for giving me the opportunity to talk on something unrelated to today's discussion. But in few ways, I would say it is related. So, biopsy is it actually needed in ILD, and in what subgroup of ILD is it actually needed, and in what way it actually benefits? Is what we're going to discuss, and little bit about the types of biopsies which we have available today in our armamentarium, and what are the advantages, disadvantages, with special discussion on the cryo, which is somewhat a new tool which has probably come in vogue only in the early 2000s. So just to start off, I want to highlight a few cases where we actually need further histopathologic diagnosis to help us establish the etiology for ILD and to further prognosticate the diagnosis, to further prognosticate patients.
So this is the first case where we had a 65-year-old gentleman who was a farmer by occupation. He came with cough and dyspnea of 1.5 years duration. There was no evidence of a connective tissue disease, and he was a never smoker. On examination, he had clubbing. His saturation was 95, and in addition, he had bilateral crackles. His CTD workup, which included ANA, immunofluorescence, ANCA, anti-CCT rheumatoid factor were all negative. And to assess his lung function, a spirometry which was done, which showed mild restriction and reasonably good FVC of 1.82 liters. So this was his X-ray, which showed primarily a unilateral disease with some pleural involvement, reticular opacities primarily in the lower zones of this X-ray, and probably something chronic going on here in view of reduction in the lung volumes on the right side. So this was the CT which was done. This was a non-contrast CT media scanning window, which is showing up a small paratracheal and a small subcarinal lymph node. Apart from that, there was this pleural involvement, which I would say is more pleural thickening than pleural effusion. And this is the HRCT thorax of the patient. Play the video. So here, if you see that there is reticular opacities, intra and interlobular septal thickening, primarily in the primarily on the right side, with some structural changes in the form of fractional bronchiectasis, and more so in the with an epicobasal gradient with involvement of the lower lobes more than the upper lobes, and there was some central involvement of the peribronchovascular interstitium as well. So this is the first case. So in this case, where you have no help from the CTD workup, you have no definite pattern on the CT, where you have some atypical findings where, although the patient is slightly elderly, it would probably fit into an indeterminate pattern of an ILD. So this would probably want further histopathological evaluation and a subsequent MDD diagnosis to establish etiology. So next case is again a 62-year-old gentleman who was an engineer and was working in a private firm. He had diabetes, he had hypertension, he was obese, he had history suggestive of OSA, and he came to us with cough and dyspnea of 6 months duration. He was a smoker, but had an insignificant smoking history. He didn't have any CTD history, and there was no history of organic or inorganic dust exposure. On examination, there was no clubbing, saturation was okay, and he had bilateral crackles. So this was again his X-ray, which showed reticular opacities in bilateral lower zones with left side involvement more than right side, and also there was some evidence of preserved or increased lung volumes on this X-ray. So subsequently, we went on to do a HRCT, which again showed a small mediastinal lymph node with some heterogeneity and necrosis in the paratracheal location. And this was his high resolution CT. You can play the video. So this again showed some amount of interstitial abnormalities, primarily in the anterior regions of the upper lobe, some tractional bronchiectatic changes, and primarily lower lobe involvement in the form of intra and interlobular septal thickening, and few areas of cystic change. Although these would not classify as a classical honeycombing, which we see in a definite UIP pattern. So this was again just stills from the high resolution CT, which shows this anterior upper lobe sign where you have tractional bronchiectasis and you have inter and intralobular septal thickening. And this was the inspiratory scan of the patient, and subsequently lower lobe involvement showing some cystic changes, although they are not characteristic to the definite honeycombing which we are used to seeing with definite UIP. So as Dr. Tanuj had mentioned that any protocol for ILD screening requires an inspiratory and expiratory film. So this was the expiratory film of the same CT of the same patient, and in expiratory film you can notice certain black areas. These black areas represents areas of
air trapping or mosaic attenuation as we call that. So this signifies some small airway involvement in a patient who has normal pulmonary vasculature, and it points to certain etiologies. But although these would again require further characterization, and it would be difficult to establish an etiology and treat the patient just based on these CT findings of air trapping and other findings of probable UIP. So coming to the third case, this was a 64-year-old gentleman who had a history of lymphoma. He was post treatment with several drugs, including R-CHOP, followed by rituximab, bendamustine, and ibrutinib when he went into the maintenance phase. He came to us with a post treatment of lymphoma several months after treatment of lymphoma when he was on ibrutinib, where he had come with cough, dyspnea, and respiratory failure. He had a CT showing bilateral consolidation. I would say it was an OP pattern. We had done a bronchoscopy and a BAL. We had ruled out infection and treated him with steroids. Subsequently, he improved partially. So this was his X-ray at presentation. So you can see that there was a diffuse haze primarily in the left middle and left lower zone, and some reticular opacities in the right middle zone as well. So this was his CT which he came with. Sorry about the, but it showed diffuse consolidation primarily in the left middle and lower lobes, left lingula and the lower lobes, and some consolidation, patchy consolidation in the right middle lobe. So he was given steroids suspecting a drug-induced ILD, but even after a low dose of steroids, a course of 2.5 months, steroids were tapered and respiratory symptoms partially improved, but then he came again with respiratory symptom worsening in the form of increased dyspnea. SpO2 was, he was again hypoxic, he had bilateral crackles, and there was a fall in FVC and FPV1 as well. CTD workup was negative. X-ray showed progression. This was his X-ray. Earlier, there was just a diffuse haze and some reticular opacities, but now you can characteristically see that there is a new opacity in the right lower zone. So unfortunately, I don't have the CT of this patient, but this CT scan done subsequently to rule out a secondary opportunistic infection like PCP or a viral or a fungal pneumonia was negative, and CT just showed us diffuse reticular opacities with primarily central involvement, peripheral smearing with an apicobasal gradient, which was more suggestive of an NSIP. So again, in this case, it was very difficult to say that this was just a drug-induced ILD, since the symptoms and the radiology progressed after the drug was stopped. So we felt that it would be required for this patient to undergo a histopathological evaluation and an MDD diagnosis following the histopathological evaluation to actually characterize what sort of ILD it is. So when it comes to an approach to an interstitial lung disease, so when you have a suspicion based on history and your clinical features and exposure history, CTD history, what is paramount is getting a good HRCT as per the protocol already, which has been described. HRCT, especially when you have some exposure history or when you have a fibrotic ILD, it is always good practice to get both an inspiratory and an expiratory film to see of evidence of air trapping, because small airway involvement helps us to narrow down the differential diagnosis and helps us to exclude certain pathologies like IPF and alternate etiologies. And it helps us to consider diagnosis like fibrotic HP or sarcoidosis or certain etiologies of that sort. So once you have a good high resolution CT, you have your CTD workup, you have assessed the baseline lung functions, you can actually look at whether it is fitting into any specific systemic disorder like a connective tissue disorder, etc. Or if it is fitting into a fibrotic ILD like a definite UIP or a probable UIP. And if your pre-test probability of an etiology like IPF is high on cards, then you can do away with the histopathological evaluation, directly go to an MDD diagnosis and start the patient on an appropriate treatment. But if you don't have any evidence of a connective tissue disease, or if your CT scan or pre-test probability of an IPF, which is an end-stage disease, and a radiological diagnosis of a definite UIP is not there, you need to consider histopathological evaluation before you go into a MDD diagnosis to see what type of ILD you have. So the gold standard for any diagnosis of any ILD, as already has been mentioned, is a multidisciplinary discussion, which the multidisciplinary team would include a pulmonologist, a radiologist, a rheumatologist, a pathologist, who would sit after the patient has been thoroughly evaluated by the clinician to discuss the clinical features, the examination findings, the lung functions, the radiology, the pathology of the findings to finally narrow down the diagnosis. So this is the gold standard to diagnose any ILD, be it CTD ILD, be it end-stage ILDs like IPF, be it ILDs which have a specific etiology like drug-induced ILDs, or certain rare ILDs like cystic ILDs, or certain other ILDs where there is a difference, there is a difficulty in diagnosis or differentiating from infection. So MDD helps us in all those, and it has been seen that ILDs can be diagnosed with higher confidence when MDD is utilized, and there is better inter-observer agreement when there is multidisciplinary discussion prior to diagnosis of ILD. So where do we actually need a biopsy in an MDD? So suppose you have someone who's a suspicion of an IPF or an idiopathic interstitial pneumonia, but the pattern on CT, HRCT is indeterminate, or there are patterns which are suggestive of an alternate etiology. So in those conditions, you definitely have to go in for a histopathological biopsy to further characterize the ILD. Or where there is lack of clinico-radiological correlation. Suppose you have a patient who's coming to you with a probable IPF. So probable UIP, where you have some changes of UIP, but there is no definite honeycombing. But the clinical features are not fitting into a UIP. Say, for example, you have someone who is a young lady who has her CTD workup is negative, or you have a middle-aged lady who is a non-smoker but has no clubbing and who's had chronic symptoms, but her CT is suggestive of a probable UIP. In that case, you would probably not think of IPF, and the pretest probability of an IPF would reduce. And in those cases, you would probably still do an biopsy for confirming the etiology and prior to your MDD. But on the other hand, if you have an elderly gentleman who is a smoker, who has clubbing, who has history of GERD, in those settings, if a probable UIP is there, you may probably choose not to do a biopsy and treat him on the basis of radiology as IPF. So sometimes what happens is you have certain patterns, there is a suspicion of HP, but you have an NSIP pattern, which is quite well known with HP. So when there is some discorrelation of that sort, a biopsy will very well help you to narrow down the differential diagnosis. And later, most importantly, it's to prognosticate. See, as far as ILDs are concerned, we have only two lines of therapies. We have either immunosuppressants or we have antifibrotics. So that is not going to change. If you have a chronic HP or a sarcoid, you're going to give immunosuppressants either way. But to prognosticate the disease, to see how the patient is going to prognosis, to know the progression, you need to differentiate the two and probably consider a diagnosis, to a histopathological diagnosis in that case. So suppose you have a suspicion of an IPF. So when would you do a biopsy in such cases? Is when you have an indeterminate pattern, but still you're suspecting IPF. There, to look at UIP on histopathology, you would still do. But if at all you have a definite UIP or a probable UIP on radiology, and you have a definite clinical setting of an IPF, then you would do away. Likewise with hypersensitivity pneumonitis. So if at all you have a definite history of exposure to a particular allergen, and you have a typical CT of a non-fibrotic HP, you can just do a bronchoalveolar lavage to see if it fits into if there is BAL lymphocytosis, and you may actually do away with not doing a biopsy. You may just prefer to treat the patient empirically. But on the other hand, if you have a patient who has fibrotic changes, where you have a probable UIP, but there is an exposure history where there is BAL lymphocytosis, where you're still not sure whether this could be IPF or this could be a chronic HP, you would still go ahead and do a biopsy. So now that you know that where a biopsy is indicated, you need to know what types of biopsies are available with us to actually characterize these interstitial pneumonias. So one is the conventional TBIP. So this is preferred when you have an ILD with a central lobular distribution. Suppose central lobular distribution, when I say when some ILD which is characterized by a lot of nodules, which has an airway centric sort of a pattern, like sarcoidosis, pulmonary alveolar proteinosis, or in certain cases, like I said, in a non-fibrotic acute HP with a typical CT pattern, you would be just okay with doing a conventional TBLB. And in certain conditions, certain idiopathic interstitial pneumonias like cryptogenic organizing pneumonia, where you have a large area of involvement, large areas of consolidation, you could still do a conventional TBLB. Conventional TBLB is very easy to perform. It can be performed under just conscious sedation in a routine bronchoscopy room with a flexible bronchoscopy. But it is not useful in diagnosis of other idiopathic interstitial lung diseases like idiopathic NSIP, like IPF, or if you're suspecting other ILDs like RB-ILD, desquamative interstitial pneumonias. In those settings where you require a larger tissue, where you require a large area of representation, conventional TBLB would not help. Especially in IPF, like it has been seen that the sensitivity of conventional TBLB is very extremely low. It is just to the tune of 20 to 25%. Even an MDD after conventional TBLB for IPF is extremely poor. It has very low sensitivity. So the limitations are that this is a blind procedure which is done in the bronchoscopy room using a small forceps. So the tissue size is extremely small and it is characterized by crushed artifacts. So exact morphology at times cannot be made out. But on the contrary, it is a very safe procedure. It doesn't require GA, it doesn't require any fancy equipment and can be done in a routine bronchoscopy suite. So coming to the gold standard to establish etiology for histopathological diagnosis is a surgical lung biopsy. So this involves either performance of a thoracotomy or a VATS, and samples can be taken. The advantages, samples are larger and it can be taken from different areas of representation, and the diagnostic yield is obviously the highest compared to other modes of biopsy. So, but on the other hand, it is associated with a significant higher morbidity, significant higher length of stay in hospital, and a higher mortality. The mortality can be to the tune of 2 to 3% in stable elective procedures to more than 15% in cases who are in respiratory failure. And obviously, because this is going to be done under GA, your patients have to be fit. They should have significant pulmonary hypertension, significant hypoxemia, and they should have a good lung reserve for them to undergo a surgical lung biopsy. So now coming to something which is new and probably the answer to the limitations of a conventional TBLB and the answer to overcome the limitations of a surgical lung biopsy in terms of complications. So this is the cryobiopsy. So what exactly are the advantages of a cryobiopsy? It is a lesser invasive alternative. Although the yield is not as good as a surgical lung biopsy, it is quite good, and it is definitely more than a conventional TBLB. There are no crushed artifacts and we get a significantly larger tissue when it comes to cryobiopsy in comparison to a conventional TBLB. So what is the evidence? So is there any evidence which has compared the gold standard, that is a surgical lung biopsy, to a cryo lung biopsy? So this was a trial which was published in 2019, and this was actually a practice changing trial which convincingly showed that cryobiopsies, when it comes to diagnostic agreement with a surgical lung biopsy, is equally good. So what they did in this trial is they randomized 130 patients who required histopathological evaluation based on an MDD to undergo sequential cryobiopsies followed by surgical lung biopsies in the same setting. So following that, 130 samples were obtained and they blinded 3 pathologists. So the pathologists were not told whether the sample was from a cryo lung biopsy or it was from a surgical lung biopsy. And the pathologists reported those specimens of the biopsies, both surgical lung biopsy and the cryo lung biopsy. And then after that, they had a blinded MDD, where another set of panelists were presented with the clinical data, the serological data, and the biopsy data. And the panelists were not told which was the surgical lung biopsy and which was the cryo lung biopsy. And what were the outcomes studied was? The outcome they studied was whether there was agreement of histopathological features for diagnosis of a UIP pattern or a probable UIP or indeterminate, and whether there was agreement of the consensus clinical diagnosis using the TBLB and the surgical lung biopsy. In other words, they saw whether the diagnostic agreement was good for diagnosis of IPF, and MDD diagnosis was whether there was agreement when they considered the cryo lung biopsy with respect to the surgical lung biopsy. So these were the results. So there was a great agreement between the TBLC and the surgical lung biopsy for guideline defined patterns, and the coefficient of correlation was 0.7, which was more than the cutoff for good agreement. And then for the final MDD diagnosis, the agreement for TBLC and surgical lung biopsy was more than 75%. And high confidence MDD diagnosis also, when it came to when only surgical lung biopsy was considered versus only cryo lung biopsy, the diagnosis, the high confidence diagnosis which was achieved with both were equally good. And they also found that out of the cases where cryo TBLB did not perform well, even surgical lung biopsy didn't perform well. That means only out of the 26 non-classifiable diagnoses on TBLC, only 6 were reclassified with a high confidence diagnosis via surgical lung biopsy. So, in other words, to say that surgical lung biopsy is, if a cryo lung biopsy is inconclusive, there is a high chance that even your surgical lung biopsy may be inconclusive. So, what were the side effects of a cryo lung biopsy? So, because this trial did a sequential study, it was hard to pick up what the side effects related to surgical lung biopsy were, or what the side effects related to the cryo lung biopsy were. But airway bleeding was significantly present when after a cryo lung biopsy, but it was more or less mild to moderate. And on the other hand, when you do a batch guided biopsy or when you do a surgical lung biopsy, invariably your patient is going to come out with a chest tube 100% of the times. But when you do a cryo lung biopsy, the rates of pneumothorax and requirement of a chest tube is only around 15 to 20%, and maybe lesser if you use a fluoroscopy or a C-arm to do your cryo lung biopsies. So other evidence was that there was a high increase in confidence after addition of TBLC to the MDD, and it was that the level of confidence was similar when TBLC was compared to SLB, and there was a higher diagnostic yield for SLB. The diagnostic yield for a surgical lung biopsy is around 90 to 95%, but cryo biopsy is 80%. So, but even this offset of diagnostic yield is advantageous in the fact that the side effect profile is much better for a cryo lung biopsy. So, and also the cost. When they did a cost analysis, they found that doing a cryo TBLB was much cheaper than actually doing a surgical lung biopsy, where the patient had to undergo a double lumen tube insertion followed by stay in CCU, stay in ICU, followed by chest tube insertion, followed by increased length of stay. So now, what is the principle? How exactly do we do the cryo lung biopsy? So in cryo lung biopsy, we have a machine of this sort and a probe of this sort. So, and this is attached to a cylinder. The cylinder is usually contains a compressed gas of either carbon dioxide or nitrous oxide. So the principle is the Joule-Thomson effect, where when this compressed gas is released, there is a cooling effect and the temperature drops to almost -50 to -80 degrees Fahrenheit. And then whatever comes in contact with this, the probe gets frozen and it is removed en masse. So what exactly we do is through a bronchoscope, we pass this cryo probe and we visualize on the C-arm where the probe is going, and we go as distal as possible into the area where there is maximum involvement of the CT, and then we release the gas. So there is the gas, when it's released, there is a cooling effect and the tissue in contact with this probe gets frozen, and once the frozen tissue is removed en masse. So the advantage is that there is no crushing artifacts, and when the frozen tissue comes out, it shears a larger volume of tissue in comparison to just a forceps biopsy. So that is the advantage. So coming to the procedure, how exactly we do the procedure is, first we need to know the CT properly. We need to know where the areas are involved and from which area we actually going to take the samples. See, for example, if there is CT of a probable UIP, which involvement of the lower basal segment, you would probably go into the posterior basal segment of the right lower lobe or the medial of the lateral, or basal segments basically, and then perform the procedure in those areas. So this procedure can be performed under either conscious sedation it can be performed under GA using an ET tube, but the preferable mode to perform this is a rigid bronchoscopy. So the rigid bronchoscopy gives us a better control of the airway. It helps us to minimize bleed, helps us to control bleeding better, and it helps us to ventilate the patients simultaneously as against doing it under just a flexible bronchoscope where we don't have control of the airway. Okay, so what we do is we pass the rigid bronchoscope into the trachea or into one of the main bronchi, and then based on where the CT involvement is showing, we can pass a flexible bronchoscope through the rigid bronchoscope and pass this cryoprobe through the flexible bronchoscope into the desired segment, visualize the segment on the C-arm, and then activate the gas. And so when the gas is released, there is freezing, and then we can remove the tissue. So this is just a video to just show you how the procedure is done. So this is how the rigid bronchoscopy barrel looks like. So once you go into the rigid bronchoscopy, through the rigid bronchoscope, you pass a flexible bronchoscope. So this is a balloon. Once you take the cryobiopsy, there's a chance that there will be profuse bleeding. So this balloon is inflated, it's called a Fogarty balloon, into the segment from which the biopsy is going to be taken. So if there is bleeding from this segment after taking the biopsy, the balloon inflation of the balloon prevents the bleeding to go into the other areas of the lung, so that it prevents further hypoxemia due to bleeding. So once you have positioned your balloon, you pass through the flexible scope, you will pass the cryoprobe into the desired segment. So this is the lateral basal segment of the, I'm sorry, can you please forward it? So this is the lateral basal segment of the right lower lobe. So the cryoprobe is inserted, then the tissue is frozen and it is removed en masse with the bronchoscope. So this is how the procedure is done. Then it is instilled into saline where the tissue which is frozen thaws, and then we put it into formalin. So other methods where we can do is we can use, instead of using a rigid bronchoscope as a conduit, we can use an ET tube. But the only disadvantage of using an ET tube is your size of the ET tube is just 8.5 or at the most 9 mm, the outer diameter. So it is very difficult to pass a Fogarty, the balloon, to pass the flexible bronchoscope, to pass a cryoprobe all through the lumen of a ET tube. So sometimes there is a chance that your balloon will get displaced and there may be bleeding in other segments as well. So to overcome this, what we can do is using flexible bronchoscopy only, we can use some, this technique has been described in AIMS where they use a ARN blocker. So this is nothing but a similar to the balloon, but it has a loop so that it gets looped around our flexible bronchoscope and you can take it to any segment you want and then fix the ARN blocker. And then again go fix the ARN blocker through the nose into the trachea and into the desired segment, and then go via the mouth and take multiple cryobiopsies. But again, this is not a foolproof technique, and there is a chance that the blood bleeding that occurs after the biopsy may spill into the other segments. Or another technique is you can use 2 bronchoscopes. One bronchoscope can be used immediately to take a biopsy, and then once you take out the bronchoscope en masse with the cryoprobe, you can put another bronchoscopy, pass a Fogarty balloon through it, and then block the segment to prevent bleeding. But then again, this will be time consuming and there is a risk that your blood will spill into other segments and cause significant hypoxemia. So what are the advantages? The major advantage of a cryobiopsy is increase in diagnostic yield compared to conventional biopsy and almost equal diagnostic yield when it comes to the gold biopsy. So this is one of the cases where we had taken cryo-lung biopsy, which shows a significantly large lung tissue which we are able to obtain. So the size of the tissue here is almost 1 centimeter. So as against 1 mm in a normal 1 to 2 mm in a forceps biopsy. So that is one big advantage which increases diagnostic yield and helps us to narrow the differential diagnosis to a better indicator. So what are the contraindications? So the absolute contraindications are high risk for GA because most of the times for rigid bronchoscopy we require GA. Hemodynamic instability and pulmonary hypertension. Pulmonary hypertension increases the chances of bleeding to several fold. So when you have pulmonary hypertension, ideally no biopsy is indicated and only surgical biopsy, that too if the risk benefit ratio warrants, should be done. Other contraindications would be again thrombocytopenia, uncorrected bleeding diathesis, extensive cysts or bullae, which worsens the risk of pneumothorax, and certain relative contraindications would be FVC of less than 1.5 liter, anemia, and significantly impaired DLCO. So now, what if your cryobiopsies are inconclusive? So if your cryobiopsies are inconclusive, there is data to suggest that maybe you can go in for a surgical lung biopsy if your patient is fit. But from the cold eye study, we have also seen that the percentage of change in diagnosis or the percentage of difference that a surgical lung biopsy makes after a cryobiopsy, if the cryobiopsy is inconclusive, is trivial. So even the diagnosis of doing a surgical lung biopsy after a failed cryobiopsy is questionable, and maybe an MDD diagnosis and initiation of therapy is the modality to go about. So now coming back to the cases. So the first case where we had gone ahead with the cryo because it was showing an indeterminate pattern. Because he was a farmer, we had considered chronic HP, and because he presented in the post-pandemic era and he had history of mild COVID, we thought of post-COVID fibrosis. Also, because there was pleural thickening, we thought of pleuroparenchymal and some upper lobe involvement, we thought of pleuroparenchymal fibroelastosis. And then sarcoidosis because of some mediastinal lymphadenopathy. So he underwent cryo-TBLB, and the diagnosis was a granulomatous inflammation with no necrosis, and lymphoid interstitial inflammation was present, primarily in the peribronchiolar region. So we made a MDD diagnosis of chronic HP with high confidence and started him on steroids. So the second case where there was the head cheese sign or the triple density sign with air trapping, we thought of these possibilities: chronic HP and probable UIP, because he was in that age group above 60, he had history of smoking, and he had a peripheral basal sort of ILD. So he underwent cryo-TBLB, and his histopathology was very non-specific. So it just showed interstitial fibrosis. So based on the algorithm, where we had a clinical possibility of IPF and we had probable UIP and some things of indeterminate UIP on biopsy, but nothing to suggest a HP like granulomas, interstitial involvement. So we made a diagnosis of IPF with low confidence and started him on pirfenidone, and he's doing okay. So the third case where we had a possibility of a drug-induced ILD, we did a cryobiopsy again, and it turned out that he had NSIP pattern even on biopsy, and because the MDD diagnosis was idiopathic NSIP, because he had progressed even after stopping of the drug. So he is on steroids currently. So now, what is the role of cryobiopsy in CTD ILDs? So just to highlight the role of biopsy in CTD ILDs as well, I would like to present a case. This is very similar to the third case which was discussed. So we had a 45-year-old lady. She had some Zika symptoms, which was obtained retrospectively. She actually had just X-ray changes on. She had planned to undergo surgery for hysterectomy, and incidentally X-ray had picked up certain changes, and then based on that X-ray changes, CT scan was done, and based on that a retrospective history of Zika symptoms was obtained, and then finally she was evaluated. ANA was positive, anti-Rho was positive, so there was nothing else to suggest SLE or any other CTD. So this was the CT. So the CT had shown just some diffuse nodules, especially in the perilymphatic nodules, subpleural nodules, and they were quite large and atypical. So this is the closer look of those nodules, and in addition to those nodules, there were some ill-defined cysts, which were more so in the lower lobe than in the upper lobe, and there was some evidence of chronicity in the form of tractional bronchiectasis in this CT. So again, here some large cysts of variable size, more so in the lower lobe, and some nodules. Okay, some ill-defined subpleural nodules, some in the peribronchovascular distribution. So lip biopsy was consistent with Sjogren's. So diagnosis of primary Sjogren's with lymphocytic interstitial pneumonia was made. She was not very symptomatic, and her FVC was good. So she was just given low-dose steroids, HCQ, and symptomatic management for her Zika symptoms. But she came back several months later, I think 3 to 4 months later, with worsening dyspnea and weight loss. So Then we repeated an X-ray which showed again new infiltrates, nodular infiltrates primarily in the lower zones on both the sides. The nodules in the upper lobes were persisting, the cysts were persisting, but what was new was a mass-like consolidation in the right lower lobe. So the cysts were again there, both in the upper and the lower lobe, and they didn't seem to have increased compared to the baseline. So then what possibilities we thought of, given that she was Sjogren's, she had a CT consistent with LIP which had progressed. So maybe we thought that she had maybe progression of the underlying ILD itself. LIP had progressed because LIP is very well known to have nodules and cysts. Or we thought of an alternate etiology like amyloidosis or a plasma cell dyscrasia, lymphoma. So we went ahead, did a cryobiopsy from that mass-like consolidation, and we diagnosed her with marginal zone lymphoma, which is a very common lymphoma in patients with CTD, especially Sjogren's. So we started her on chemo, and currently she is doing well. And the CT has shown resolution of all nodules actually, but the cysts are persisting. So probably her LIP has responded along with the steroids for the chemotherapy, and the lymphoma is also resolving because of the chemotherapy which was given. So the final take-home messages from my presentation are that an MDD discussion is the gold standard for diagnosis of any ILD. Biopsy is required for selected patients of idiopathic interstitial pneumonia, especially if your IPF is there, if you're suspecting IPF, if you're suspecting a low pretest probability of IPF, along with a probable UIP or other idiopathic interstitial pneumonias. When it comes to biopsies, we have conventional TBLB, surgical lung biopsy, and cryo-TBLB. Cryo-TBLB may be the best option in these cases because of acceptable diagnostic yield, good agreement with surgical lung biopsy, and with minimal complications, but it comes with a learning curve because the ideal setting requires rigid bronchoscopy. Thank you. If there are any questions. So transthoracic lung biopsies are more so for a malignancy. When you have something which is more airway centric, the role of transthoracic biopsies become less, and more so if you have to do a transthoracic lung biopsy, the risk of pneumothorax, especially with the structural lung disease, is extremely high. So when comparison to bronchoscopic techniques, transthoracic lung biopsies with structural lung disease is a little less. So you can do transthoracic lung biopsy. Say for example, in the case of Sjogren's, which I showed, where there was a peripheral large nodule, there probably a diagnostic yield of even a transthoracic biopsy may have been equally good. But because in this case there were a lot of cysts and we were suspecting that there may be a high risk of pneumothorax with a transthoracic biopsy, we preferred a bronchoscopic biopsy over a transthoracic biopsy.
Compared to surgical lung biopsy and transthoracic lung biopsy.
So, sir, transthoracic lung biopsy again will have the same. In fact, transthoracic lung biopsy again you will get very few tissues. Advantage of a surgical lung biopsy is you can take biopsies from multiple lobes. You can take one sample from, depending on the area of involvement, you can take either from the right middle lobe, right lower lobe. So your representative samples will be much higher, size of the sample will be much higher, and you will be more likely to reach a diagnosis when compared to a surgical transthoracic biopsy. With a transthoracic biopsy, it will be very difficult to put in one. You put in a needle, a core biopsy needle or a true cut needle into the lower lobe, then one again into the upper lobe. So that representative sample will be less, and obviously size of the tissue is much larger. So you get 4 to 5 centimeters size of tissue with a surgical lung biopsy is almost 4 to 5 centimeters, as compared to a transthoracic biopsy, which may be as good as a conventional TBLB.
What happens if we treat our patients without a biopsy? Just based on clinical suspicion, what are the risks? Why should we get a biopsy?
So, see, obviously, to a certain extent, it is going to be practice changing. Suppose you have a patient of probable UIP, okay, but any end-stage lung disease can go into a probable UIP. So, but if you have a probable UIP and your CT and your histopathology shows some granulomas, some evidence of sarcoidosis or some evidence of chronic HP, that way, so in one way it will be treatment changing. So there are studies which have shown that when you have fibrotic lung diseases and you do biopsies, almost in 20 to 25% of the time, it will be treatment changing. One. Two is you will be able to prognosticate your patients better. You will be able to assess the disease progression better. So timely you can refer them for escalation of therapy, or you can refer them for lung transplant. So these are two things which, so like I said, treatment options we have are only steroids, immunosuppressants, and antifibrotics. So, but even then, biopsy has a role in prognostication.
Guidelines haven't changed it. It's still against surgical tissue biopsy.
In certain, I think in certain.
These are the exceptions.
So what we practice in our institute is that after an MDT meet, if the clinical, radiological, and with lab parameters, we come to a conclusion. Because we have made a clinical diagnosis, a radiological diagnosis with all lab parameters. Whenever you have an unclassifiable IND, okay. Whenever you have IND which is not improving your treatment, then you go to biopsy. So biopsy is the last option when you don't have any. Initially, we have done a lot to gain our own experience, are we right or not. But once we are confident with the clinician and even like the rheumatologist, everybody is sitting together and you are confident you have to give this diagnosis.
And is cryo your option?
So for us, cryo is the first option. Okay. Second is TBLB, and third is VAPS. Based on where the location of the central of it.
Cryo can be done in a lot of other settings also. Suppose we have an undiagnosed, if you're suspecting a malignancy, where you require a larger tissue, where your conventional TBLB or CT guided transthoracic biopsy is negative, you can get a larger tissue with minimal complications even for diagnosis of a malignancy. So even that can be done, although it is not recommended as such. But we have found that diagnostic yield is pretty good. I mean, compared to, especially when other modalities fail, especially with central lesions, they can be done. Cryo can be done even in those scenarios.
You can add foreign body also.
Yes, we can.
Foreign body also.
There are certain organic foreign bodies which we can freeze and remove. Certain foreign bodies like metals are cryo resistant. So we really can't use cryo there, but it's very easy, you know, the foreign bodies just stick to the, especially if they are acute foreign bodies, it's easy to remove with cryo. Also, central airway obstructions can be managed with cryo. You know, you can debulk, you can just freeze the tissue and remove tissues from the trachea, main bronchi, and debulk the airways very quickly with cryo. Thank you.
Thank you, Dr. Bharat, for the elaborate presentation. We are at the end of the ending the session of this today's program. And before I go on with vote of thanks, I request our HOD, Dr. Pragati, Madam, to felicitate and give away a token of gratitude to the speakers. I will now call up Dr. Pragati. Thank you, sir. Thank you for taking your time. Without what we understood from the morning, since the discussion from the morning is MDD, multidisciplinary approach. So they are definitely radiologists to play a lead role in diagnosing chronic confusion. I like to call Dr. Ashwini ma'am. Thank you, Dr. Thank you from behalf of Medical College and the Department of Respiratory Medicine. May I request Dr. Gayatri Madam to just give away token of opportunity to Dr. K. N. Shivaswamy sir, Professor of Dermatology. Thank you, sir. Going to follow it's really been really nice. Ma'am, please give away Dr. Karthik. Thank you, Dr. Karthik, for elaborating on the ANA. So now we know when to use the ANA. Yes, here. So, Madam, please give away to Dr. Bharat. Information on Centenary and critical care medicine. Thank you, Dr. Bharat. Thank you for the elaborated discussion on the need of lung biopsies, whether it is conventional biopsy or it's a cryo-lung biopsy or new tool. I request everyone to please stay back for the group photograph. And I end up the session with a vote of thanks. To start with, the Honorable Chairman, dignitaries, respected senior professors, the most valued invited guests. Ladies and gentlemen, it is my privilege that to have been asked to propose a vote of thanks on this occasion. This CME was organized as a part of the centenary celebration of our founder, chairman, and the visionary late Dr. Ramaiah, whose blessings we eternally seek and are privileged to receive. I, on behalf of our Department of Respiratory Medicine, extend a hearty vote of thanks to our Honorable Chief Patron, Dr. M.S.Ramaiah sir, Principal and Dean, Dr. Shalini Noy Madam, Dean of Academics, Dr. Medha Rao, President Ramaiah Memorial Hospital, Dr. Gurudev K.C., and our Associate Dean, Dr. Harish K., for their gracious and constant support, encouragement, and guidance. I also express my heartfelt thanks to our Senior Professor, Dr. Gayatri Devi HJ, ma'am, for being a support, constant encouragement, and kindness at various stages of our training. I would like to thank our beloved head of the department, Professor Dr. Pragati Rao, ma'am, for the opportunity, help, guidance that radiated a source of energy within us. No conference, event, or any function can take place without a hardworking leader. So we will ever remain grateful to you, ma'am. I am very much thankful to our current faculty, Dr. Manjunath, Dr. Tanisha, and not to forget our colleagues, Divya Davis and Vijayalakshmi, who's also been a part of our Respiratory Medicine department, for standing by us and motivating us. I feel proud and thank you for making this event a successful one. I would also like to thank our honorable delegates who blessed us with their presence. Thank you. Thank you for your participation. And I'm also very much thankful to the invited speakers. So thank you, sir. Thank you. And words are not enough to thank their constant guidance and support to shape the conference. Thank you, sir. Ladies and gentlemen, thank you very much for your presence and making the time to be with us today and helping us make this event a grand success. Thank you, one and all. I invite one and all, please join for the group photo first, then later on for the lunch in the NOC. Yeah, I mean, all those who have been registered, you will receive an e-certificate only if you are registered and send your email. Please fill it up. And yeah, definitely, please hand out the feedback after the session. Thank you so much. Thank you.
Thank
The group photo will be taken near the steps, near the entrance. Please assemble there.